That, how can you be medically qualified and not know that? That's actually schoolboy biology. It's not, everybody knows that starch is glucose molecules holding hands. You've got a problem. Should we start metformin today? And you'll need that for the rest of your life. Or are you interested in doing lifestyle? Because I think that could really work well for you. You could be so much better in a few months. Not a single person has turned me down, not a single one. Fireworks going, sparkly things were happening in my brain. It was so delicious and the lights were all flashing on and off. Oh, this is fabulous. The next morning though, what a crash. I had a mixture of anxiety and depression. And it lasted for 2 whole days, that one pudding, the effect of it.
Whoa.
Yes, yeah. And she said, I was surprised too. So now she said, what I do is I spray bleach on the bread and leave the can of spray bleach by the bin so he knows don't even bother because every bit of it's got bleach on it. And she said, only bleach will stop my husband from eating bread. And that's the best way I have of helping you understand ultra-processed food addiction.
Tell me who you are and what you do.
I'm Dr. David Unwin. I'm a family doctor in Southport, which is just north of Liverpool in the northwest of England. And that's what I do. I've looked after the same population of people I really care about for 40 years. So I've looked after at least 3 generations of people.
Wow.
So in every clinic I do, I'm meeting people I've known so well for so long. And I'm 67. I can't bear to give it up. I'm actually now the oldest working doctor in something like 100 miles radius of where I am, because all the other doctors all finish when they're 55 or 60. And I'm still there, like a freak.
Well, we're going to get into all of that. As you know, in the podcast, I like to get into the background of the guest, especially to inform where they're at. And then to talk about your current position, we kind of intermix it all. But then we also have from the desk of Own Your Labs, we're our own sponsor. So if anybody wants to submit questions for you or future guests, go to ownyourlabs.com/desk. But these will be up a little bit later. So yeah, let's go all the way back. When did you first know you wanted to become a doctor?
Right. So when I was about 9 or 10, I became fascinated by natural history and animals and birds. And I was always rearing baby thrushes or birds in my bedroom, or had frogs all over the place, that kind of thing. And I ended up volunteering to work in a bird sanctuary when I was 12, like working for free at a bird sanctuary and learning how to rear baby owls and care for animals. I loved it. I was so happy there. I went all my free time I spent there. And it had a massive, massive effect on the rest of my life, partly through the animals, and partly one of the big friendships of my life was, funnily enough, I thought she was a very old lady and she was 55 years old. So I remember thinking she's very old, but she was so clever. She ran the bird sanctuary and became a very close friend, and she taught me a lot. That as a life experience, it was amazing, because we had no money. The bird sanctuary never had any money, and so I was trying to raise money for the bird sanctuary from the age of 13 and showing people around, then trying to get donations. I was mixing with a terrific, all sorts of strata of society would come, from sort of aristocrat people right down to very poor people. So it was intensely interesting and stimulating. And out of that, I will answer your question. Out of that, I wanted to become a vet. I so wanted to be a vet because I thought that's the only thing to do with all the skills that I'm getting and how I'd like to spend my life. Unfortunately, in the UK, it's more difficult to become a vet than it is a doctor. So weirdly, your vet is probably better qualified than your actual doctor. So that's hilarious, isn't it? So there was another factor which is very important in my development. I have quite severe dyslexia. And this gave me many problems, but also some strengths. But the problem was that even education was a problem for me. And so it became obvious that I was never going to be a vet and I would have to compromise. And that compromise was to become a doctor. And I thought to myself, well, you can still do animal stuff as a hobby, which I still do. And now we live on a farm and I have the hens and the geese and the sheep that you've seen. I run 5 bird reserves. So I have another life altogether running bird reserves. Wow. For British wildlife. And, I was there this morning. I've got amazing wildlife and it balances my life. But anyway, to keep to thing, it was obvious I wasn't going to be a vet, so I compromised and I only just got into medical school. Only just. It was so hard for me because of the dyslexia. Dyslexia is you can't sequence, so I can only remember 2 telephone numbers in the world because I can't sequence numbers or letters very easily. So I can remember my mother's telephone number because I've managed to memorize that, and the house where we've lived for 30 years, no other numbers. So all sorts of aspects of learning are quite difficult for me. But by sheer determination, which that's what you learn from being dyslexic, that you have to be original, you have to find other ways to learn, other solutions to problems. So you see, I had a bit of an engineering mind because for me to learn the pharmacopoeia, the drugs that we used at medical school, was a nightmare, an absolute nightmare to have to memorize whole books of stuff. Very, very difficult. But I would always find ways around that. And eventually I ended up at Liverpool Medical School, but continued. I never lost. So that bird sanctuary with the old lady who became one of my best friends in my life, I'm now senior trustee of that whole organization because I've just outlived everybody. So I've done that for 50 more years. So if I started when I was 12 and I'm 67, that's 55 years I've done that. And aspects of it come into the story again and again in different ways. I'll give you one thing. So I used to really, for years and years, think about, nature. So I'm very observant. Very observant. To be a doctor is to be observant of people. By the time you've sat down, I'll bring you in from the waiting room. By the time you've sat down, I've got all sorts of hypotheses about you. So looking at you now, you're healthy. I believe your eyes are bright. You're full of attention and energy. And I've observed that kind of thing. So I'm very observant, but I'm observant of nature. And what struck me was, why do humans all look so sick? So you just go along any street, just look at those human beings with the eye of a naturalist. And, in nature, the animals you see are sleek and fit and at their best. And yet you go along a street in Liverpool or in the north of England, and the number of people you would look at and think, you are a fine specimen, you are healthy, is small. And I was puzzled by this for decades, that I had all this experience in the bird sanctuary and of dealing with animals, and they, yes, some of them look sick, but most of them in nature look really great. And I used to think, well, probably the sick ones just die, and maybe that's why it is. But I wasn't properly satisfied by why do so few 30-year-olds look that good? Because they should be in their prime, they're in the middle of their reproductive thing. So all sorts, the nature thing led me to be observant, because I think it's fair to say I am odd, really, as a doctor. And the things that make me odd, I think one is this background in nature, being observant, and the other is curiosity. I'm a very curious person. And I know some of my colleagues don't seem to be so curious because they're seeing the same things that I see, but they don't think about it at all as interesting.
You're talking the core of scientific inquiry, right?
Yeah.
Is you have to have the genuine passion to want to sort these things out. You discuss, for example, why it is that we're just watching humans getting sicker. And two things that I feel I'm confronting more and more is, even before getting into this space, to your point, I would just keep thinking about what I observed when I was a kid, and now what I'm observing when I'm near a school.
Yeah.
And what I see with kids today, they don't look like the kids that I was growing up with when I was a kid. And kids, they're at the beginning of metabolism, right?
They're so important. They're our future.
Exactly.
And yet we're asleep at the wheel. We're fast asleep at the wheel. And the kids, they should be the most precious thing that, your nation and my nation, our care of children, and perhaps old people too, but our care of children marks civilization. And yet look around and think about how are we trying to facilitate young people to become their best selves? And I don't think we are. I think we're letting many young people down.
Another one that I remember seeing myself along the lines of what you're describing is, I kind of went, well, it's probably because of knowledge work. A lot of us are sitting in cubicles.
Yes.
Whereas the folks that preceded us, they typically had more labor-based jobs. But it didn't fully compute, because I could still look at, say, construction workers today and look at comparably construction workers 50 years ago. And there's a night and day difference, right? So it's not just as simple as a lack of exercise because more of us are, able to work at a desk computer.
You're right. So many things I've observed that. So I told you at the beginning, I've got many families where I've looked after 3 to 4 generations. And what I'm seeing is that people, every generation is fatter at a younger age.
Right.
That's, I've really seen that. So when I started in 1986 in Southport as a partner. I was very proud. And we had hardly any seriously obese patients, hardly any. It was really rare. I remember the ones, because there were so few of them.
How big was your practice?
10,000 patients, it still is.
10,000 patients at that time? And
it was about 9,000 and now it's 10. So
wow.
It's slightly bigger now, but it's quite a big practice. So and I know them very well.
Just because I know a lot of us Yankees are going to be listening to this podcast, can we talk just for a moment on the route to becoming a doctor in the UK?
Yeah.
As I understand, it's actually a little shorter.
And also, I think we need to discuss what I mean by a family doctor. And so some understanding that is key to interpreting the data that I have, because it's different from the States.
Right.
So my route to being a doctor was 5 years at Liverpool Medical School. And then I had 1 year as a house officer. And then I had a further 4 years going round all the various specialities. So I do 6 months in pediatrics, 6 months in geriatrics, and mob and casualty, and doing that. And then a year, that would include a year in general practice. So that was the full speciality training.
You said that's 4 years?
Yes.
Wow. So correct
me
if
it was
I'm wrong.
for me. It was for me. So there was a year, the whole thing took 5 years, but so there was a year for me as a house officer.
What's a house officer?
A house officer, you've just qualified, so you're properly qualified doctor, and you're always working in a hospital, medicine, surgery, but you take all the bloods, you put up the drips, you take the histories, you examine the patients, but you don't make so many clinical decisions. That's called being a house officer. And then you use that and think, after that you think, well, what would I like to specialize in? So at that point you need to decide what you're going to specialize in. And I decided to be a general practitioner because, believe it or not, I went to the practice I'm in now as a medical student. So I started there in 1978 as a medical student, and I thought it's just so fascinating. I thought general practice family medicine would be really, really boring. It was very interesting. It's full of psychology, full of drama. And the old senior partner, who is now 94, he knew about every patient, and he could say, he would know about their parents, their jobs, their hobbies. And now I know that about many, many people. And he made general practice, to me, I thought that's very interesting for a career. That was my first choice. Partly because I was more introverted in those days and shy. And I thought, I don't want to be a tiny fish in a big pond. I want to be a bigger fish in a smaller pond and make more of a difference. I thought I want to work in a small community. And so then so that's all that time. And so you've got the year, then you've got the 4 years. And then in terms of a permanent job, you want to become a partner in a practice. Patients are allocated to us by the state. So I can't pick my patients. And that's why my data is different, because the government allocate those 10,000 patients according to address to a GP in that area. So my patients are allocated to me, and I can't really, there's only their death or mine separates us in the end. We're stuck with each other. Very rarely I can put people off the list, and I've done that 4 times. 4 people I couldn't get on with in 40 years. And it's a wonderful discipline as to how to get on with people who initially you might struggle. But you'd be amazed how you can find, so that this is the British National Health Service, patients allocated to us. They can't take another doctor easily at all. So they're stuck with me and I'm stuck with them. But it means that the data we'll discuss eventually is real world data that you'll understand immediately, because I can't cherry pick. I'm in the north of England in a poor area.
What's their criteria as to how they assign who gets what patients?
Oh, postcode.
So it's just postcode?
Yeah,
okay.
That's the only, and you'll understand immediately that's a very important point. So all of my work is about showing what's possible in the real world, because I believe there's huge differences between real world data and RCTs, which I'd like to come back to later. But you'd have to, at the beginning, understand my patients are allocated according to postcode, and they don't move around that much. So that's it. That's why I've got this. It's a wonderful opportunity, because so many of them, I really know them well after 40 years. Some of them have moved in and some die and move out, but it's a reasonably static population. And so then in the practice I work, we have 9 doctors, and I was the senior partner. So you're a partner, or I was the senior partner. Now I've sold out because I just want to concentrate. I only want to do this work, metabolic work. I don't want to deal with complaints or staff or anything else. I just do. But that's the framework in the health service that I'm working. And it's very different from anybody you know in the States, because it just isn't possible in the States that kind of way. And it's why what I do is unusual and I believe valuable.
Well, and we'll get into that. Let's go back to 81 for a sec.
Yes.
Because there's a long stretch between 81 and when you actually get into the low carb.
A long stretch, yes.
So would it be fair to say that you were practicing pretty conventional medicine?
Completely fair.
Yeah.
There were some things that were beginning. So all those years, what was happening? A slow period of disappointment, advancing disappointment in myself, because I said, I fought to get to medical school and really, really fought. It was incredibly difficult for me with the dyslexia. And why did I fight? Because I was passionate about making a difference. That's why you do it. And I got the whole thing, find a small community and help them. And this also fits in. There's another thing to understand about me, a basic psychology that I've only worked out recently. Why am I trying so hard? Why on earth am I not lying on a beach? Why is this old guy? Why the hell am I doing it? And some of it's to do with self-esteem, I think.
Yeah.
Because, so my background, my family were reasonably what you call posh. That means they were well educated and had gone to good schools and they spoke with a certain British accent. But those same schools would not have me. And this is a tragedy. It's upsetting now to think about it. But I was toted around as a kid and no decent school would have me because I couldn't pass the exam. So I couldn't go to the sort of school that my family went to. So I was different. I ended up going to a very, very rough school with a lot of violence. And to do your homework, you had to learn to fight, because the idea of doing homework in the schools I went to was ridiculous. And I also had this posh accent, which marked me as other. And that is very different. I've a lifelong hatred of prejudice, because of whatever form it comes in. It's a terrible evil if you're the person subject to prejudice, as I was, for being posh. It's horrible, horrible, horrible. I didn't have any friends for years, no friends at all. And I had to learn to fight. So you'll notice I've got a lovely gold tooth. Well, that happened because the only way to be left alone, because I wanted to do well, I enjoyed education, was to fight. And I've always been this size. I got to be very big very early because I had early puberty. So that was great. So I was physically big and I could fight. So that then what happened was it became an idea that two of them would fight against me to see if two of them could beat me. And eventually there was a terrible fight, and there was two boys against me. I once mentioned their names in a podcast, but we won't because they're probably still alive. These kids, and I bear them no ill will at all, but they punched that tooth clean out, root and all. And that was what I had to deal with. And that's so you have all of that and being toted around schools and failing and disappointing. I remember I had a girlfriend called Alison Beach when I was 12, and she got into the posh school and I didn't, and it was yet another failure. And I think I'm still trying to prove myself now. I don't think I've quite recovered.
So many things you're saying that I relate to.
Yeah.
Because I think that for many of us, and I definitely count myself among those who've had early struggles and become late bloomers, we kind of feel like we're just never catching up enough to our own satisfaction, because there's this sense of, I knew I had the potential. And finally, I can get realization.
Yeah.
But there is this other component, which I think you touched on very eloquently, which is that you know what it is to be subject to bullying. You know what it is to be the victim. You know what it is to feel like you're kind of in a pretty hopeless spot. And I think a lot of people don't realize that about struggling with something like dyslexia, is it isn't just that, oh, things are a little tougher. It's also that you have to keep in this loop where you're struggling and have to deal with this day-to-day problem that's affecting every aspect of your life.
Well, and I didn't even know it was dyslexia because it didn't exist.
That's right.
So it was worse. Now, my brother also had it, and my father, and since then, 2 of my children and 3 of my grandchildren. But when in this time, dyslexia didn't exist. So my brother was sent to a psychiatrist as like he's mentally ill and lazy. So I didn't even have the model in my head. It wasn't possible to know what the problem was. And also, when you're young, you think everybody's like you are. So it didn't occur to me to discuss the idea that I find sequencing difficult or anything, because I thought I'm just not that bright. And yet I was driven. So it's a very odd thing. So I didn't know I was dyslexic till my daughter was diagnosed with dyslexia. And by that age, I was 35. That's the first I knew of it, because my daughter was failing at school, just like me. Clever kid falling behind with reading. And I went to the assessment, and during the assessment, I realized that's me too, because I was watching what she was doing and I was the same. B's and D's flipping around, all weird stuff. And I realized I was and then I had a model for what was wrong. But you're also right. I have a sense of, I like to feel, it may be an arrogance, I like to feel I have a sense of justice and a sense of an underdog it's not fun. And you should, you should lend them a hand. And as a doctor, you're in a great position to do that. Or you should be. So I identify with what you say, and you can read about a thing and then you can live it. And as I say, having no friends at school and bullying. My mother used to say, never let them see you cry. It was hard for her because I'd be blubbering, not wanting to go to school because I had to face this thing. She said, never let them see you cry because you will make it worse. Now off you go. Off you go. Wow. But she had no choice because they tried very hard. But, so many things have a good side and a bad side. As you get older, you see balance, and there's a good side, and all that sounds bad. But actually, what it taught me loads of good stuff. I'm very tenacious. I'm very hardworking, and I can find novel ways around things. And all of that's been a gift because I've had loads of fun in the last 15 years. So yeah, you were just saying about, so there was, going back to what was going on, because something else important was my life has been a very unusual life. Very, very unusual. Where to begin? The other thing is, I fell madly in love at medical school with my first wife. But that was to end in tragedy because she was a drug addict and an alcoholic. And I didn't really know what that meant. But I lived with her for 12 years, and I came to understand the fear that comes with living with uncertainty. I had no idea what would happen. We had the police, we had all sorts of very, very difficult situations that people living with somebody with addiction face. And I faced those on a daily basis for 12 years. And I told nobody because I was loyal. I didn't tell a single person. Partly because at that point, I thought maybe it was my fault. Maybe being married to me, was it something about me? So I was trying to get her help, to sort it out. So that, again, being strong was very important, because I was then senior partner, and then you've got this very, very embarrassing thing. Now, eventually, she killed herself. So that has been another thing that all fed into the person I am now. So I don't regret much of it, because I've learned lots from each. And then I was so lucky because Jen, the current Mrs. Unwin, came into my life, and she brought psychology with her, because she is a psychologist. And I began to see how much psychology matters to everybody, but also particularly to doctors, and we'd had no training in psychology at all. And yet so much of what we do is about behavior change, enabling behavior change in other people, if you're going to be an effective doctor. So this was, I was head over heels in love, and she's just the cleverest woman in the world. She's so amazing. And she's come from the planet psychology. It's really intense, fascinating. So we've been married 30 years now.
Wow.
But psychology was happening before metabolic health. And that was I was so lucky, because this is the foundation of getting good results. You cannot get good results just by telling people you do this. Or if you don't do this, we'll chop fingers off. Or that's all nonsense. Psychology is key to behavior change, and I'd learned a lot about that So
now we're to 96. If you just met Jen, you said it's 30 years ago.
Yeah, that was right. So that was there.
Can I ask how you guys met?
Yes, well, that's weird as well. Everything's weird.
Weird is good. So
yeah,
what long podcasts are
for? So podcasts. So Jen is my god sister.
Oh,
there we are. And I'll tell you what that means. What that means is my mother was her mother's best friend from the age of 5. And my father was her father's best friend from the age of 11. Wow. In these posh schools. And so Jen's mum and dad were my godparents, and my mum and dad were her godparents. So I've known Jen since she was a baby. She's much younger than me, and she actually came to my first wedding. When she had no idea I would, she was, my first wedding, she was probably about 16. She came because my parents' friends came, and my godfather came. And so, right, so when there's so much drama, let's cut the drama a bit. I was left, let's say this, I was left with an 18-month-old little boy and a 7-year-old girl as a single parent. So I also have done single parenting. And that's very challenging. And you're lonely.
As a working doctor.
Yes.
And a partner.
Yes, yeah. And you're lonely. You're very lonely because you get home and you have loads of the, feeding, the nappies, there's loads to do. And then when they've gone to bed, you're completely alone. And you can't go out because, and also, well, who would you go and see or what? I was very lonely, and I hadn't seen Jen for years. But my father said to me, both my father and brother said, David, ring Jen, ring her up. And we fell in love over the phone, head over heels, very rapidly, hours and hours on the phone. So much, by 3 hours, we were still on the phone saying, oh, well, it's time to go. And then we couldn't leave it. And eventually your ear really hurts because you've compressed it against your head. Because those phones in those days were the phones that did that, so it wasn't a mobile. And we knew, and then we met. I fell in love in a moment. And I know the moment I fell in love, she gave me what we call a bold look. A bold look. And it just went like an arrow straight in. I knew then I was helplessly in love. And we knew within 2 weeks that we would marry, but we didn't tell anybody because of the complex family situation. She was a younger woman. She had no idea about the needs of all these kids because it's quite complicated, She didn't know any of that. So it took us years to sort of gradually edge her into the family so the kids were fine. And we took, as Jen says, it took 7 years to build our family. 7 years from start to finish for them to feel, she was a mother to them. And it was fun. It was great fun, but we had to do it gradually. And then eventually we have a child of our own, Edward, later, so that we ended up with 3. So there's I had loads going on.
That's a great story.
Thank you. I was busy.
So now she's in your life.
Yes.
She's bringing this whole new dynamic to you.
So interested. There was the psychology. What was she really good at? Right. So at the time she was doing CBT, which is a type of therapy, but I was learning how to do it because I thought this is a useful tool. This is powerful. I want some of this. But it was time consuming and I only have 10-minute appointments. And in those days, I didn't have 10-minute appointments. Many of them were 5 minutes. Can you imagine? Whatever somebody comes in with, I'm supposed to sort you out in 5 minutes. It's unbelievable now. Then luxury, 10 minutes was luxury. So this leads to a specific thing. Jen had a pivotal point in her life where she started up on brief solution focused therapy. So this is look closely at CBT, but what makes a difference in CBT? And this has been refined into brief solution focused therapy, of which Jen became the national president of this association. So she became a national expert on psychology done fast, very fast. She herself has refined even that down to something even faster, which you'll have to ask her about, called the GRIN model, which she and I have published and written up. And that was uniquely suited to primary care, which is behavior change very rapidly. It's like magic. And I often talk about, the art of medicine. So there's always this thing about the science of medicine and the art of medicine. And I was, up until around this point, I had thought that the science of medicine was really important. So this is being an up-to-date doctor and knowing the drugs and the side effects, knowing the tests. But isn't it just interesting for a moment? Let's think about a doctor 100 years ago, or even before. So if you took a doctor, let's say around the year 1900, an up-to-date modern doctor, the science would say that heroin was great for use as a cough and strychnine was good. Okay, so that's the science. Science changes surprisingly. And it's still changing now. And many things, science changes, or it should change, and you can be wrong. And science requires humility because within it, in 50 years, other doctors are laughing at us. They'll be laughing at me now in the future, thinking, ha, he believed that nonsense. But what doesn't change is the art of medicine, the art of how we handle other human beings, how we use compassion, psychology, the continuity of care. All of that is the art of medicine, and that's timeless. But isn't that the thing that's worth learning? Because it's timeless. So many of the things that were the art of medicine before still are and will be in the future, because it's about dealing with the human condition, what really works. And so again, I spent all this time learning about the science of medicine as I thought. And I began to realize through Jen that no, there's half of this missing. There's half of it missing. And all of the most complex cases you have in primary care, the most difficult ones, the science doesn't help you very much. So it's stuff like men who are breaking their hearts because their marriage is on the rocks. They come in, big men, they just burst into tears. They can't get anything out of them. They're so distressed. Well, what we're going to do, they need help. Oh, antidepressants. Well, no, they've got a problem. They have to help them. And I began to see that the most interesting and complex cases required psychology and the art of medicine. Often it's whole families in distress, whole families going through a very difficult time. So I began to think about the art of medicine, the timeless nature of it. I remember in South Africa, I met a lady shaman in a mud hut with skins hanging everywhere, and she was about my age. And when we sat down to talk about what we believed in the way we handled patients, it was so similar. I couldn't believe this lady dressed in skins in an African hut, but it was like talking to a colleague, because her experience of caring for people and the sort of tricks I use, the psychology I used, she got it. And a lot of older doctors come to very similar conclusions when I chat to older doctors, particularly family doctors. You work out, you do more of what works. And that's to do with the art of medicine. And psychology is a big part of that.
But there's this disconnect. You mentioned earlier the amount of needing to memorize, for example, for medical school. I even had a doctor who very early on in my journey coming into this space would regularly call it memorization school instead of medical school. He says it's just really about memorizing, right?
That's true.
That 90% of what he did in going to medical school was memorizing. And that a lot of it is just matchmaking. And it's a bit of probably comes off as a bit of a pejorative, but I myself had this term that I called boldface type medicine, which is if you've got only the 10 minutes, my experience with my general practitioner is he's walking in the door and he's already got my blood work in one hand and he's scanning for the boldface type. He's like, he's going, your CMP looks good and your CBC looks good. Oh, actually, this one is out of range, which is what makes it boldface type and so forth. And there really is only that discussion from a near prescriptive standpoint from, the first second he's entering the door, right? So this broader discussion, even at a surface level of behavioral change, it's not that it's absent. It's just that there's already kind of a posture that, well, of course, get more sunshine and exercise, get more sleep, and that kind of stuff. It feels like a distant secondary subject and really not something my doctor is expecting to spend time really being serious about discussing with me. That's something I should be seeking elsewhere to accomplish.
Yeah. And of course, it's a real problem. It's a very serious problem. There's all sorts of things to tease out in there. One of them is that as a young man, I saw myself as a scientist, but I wasn't. All I was doing, as you say, was memorizing, trying to memorize stuff, looking for patterns. And it was like, which tests? So it was always like, the symptoms lead to the tests lead to treatments, which tend to be surgical or medical.
Right,
It's
exactly.
like a funnel. It's like a funnel. But nowhere in there is causation. And also science is to do with a hypothesis and challenging. And there was no sort of, that's not really science. And yet we think, I thought I was a scientist. I thought I had a scientific degree. But nowhere was I taught about what science means, or the null hypothesis, that kind of thing. And yet we come armor plated with, well, but I'm quite a high ranking scientist. And of course I wasn't. I'd memorized a lot of stuff. But again, the dyslexia was my friend, because I discovered that if I could understand why things happened, I could remember it better. So that instead of memorizing all these disconnected things, if I could find a pattern underlying it, then I just remembered it more easily, because I understood, oh, well, that's what, explains it. So that was already starting to happen for me, where I was sometimes interested in causation, but I'd missed diabetes completely out of that.
I think a lot of it is that there's a sort of almost an entrenched blind spot.
Yeah.
If you're going through medical school, you understandably assume that what they're teaching you is what there is.
And it's important.
Right. That
Yes.
For the thing you're doing, we're going to give you a lot.
Yeah.
And it's within these bounds. And so there's this kind of mindset that I tend to run into with doctors where, just as you mentioned, medication or surgery, that's the toolbox.
Yeah.
And
then you've got the fluffy stuff.
Yeah, the fluffy stuff.
And they say, of course, you should do that.
It's almost like a head pat.
Yeah.
It's kind of like, of course, do the stuff.
Yeah.
But I can't control that. That's a you thing. You came to me for the serious, real solutions. And that's going to be one of those two buckets, or both of them.
And that leads me to another point. I hadn't realized that we train our patients. We are training them in every single consultation we have. And they look to me for an interpretation of what's important.
Yes.
So that if I am dismissive about something, they are. So if I don't seem to think that exercise, sleep, and diet is important, then they don't think, they think, oh good, I don't have to bother. Oh good, I can carry on eating because I quite like donuts, but I'll take my drugs, because they think Dr. Unwin is concentrating on, are you taking your tablets, and let's do the blood work. And this leads into, I'm always asked, well, why won't my patients, Dr. Unwin, why won't other doctors say to me, well, why my patients won't do that?
Right.
My patients won't. So either I'm a fraud, which is possibly true, or something's weird, or I'm a magician, or whatever. But it's to do with the signaling, the psychological signaling that we give out all the time. So my time is spent weighing people, because weight's really important. My time, I will measure waist circumferences. My time is asking you about what you're eating, what you're hoping for. And there's a lot of talk of diet and exercise. So my patients are left in not at all uncertain about what I think will help them and the route to improved health. Because I'm living it, and in every, in that 10 minutes, that's what we're talking about.
Can I give you one of my least favorite examples, but definitely one I prioritize on the topic of signals coming from healthcare, is hospital food. So what are you telling patients?
Yeah.
Never mind even the food itself, right? When you're in a state of being cared for by medical professionals,
Yeah, you're helpless.
what is the food that's being put in front of you says everything. Getting back to what you're talking about.
Do you know, that's a great point you've made, because this is supposed to be a cathedral of health.
Right, exactly.
A hospital. We worship health here, and we're going to cure you.
We're the experts.
Yeah, we are the experts. We've got the white coats on, the machines that go ping and bleep are all around you. And clearly food doesn't matter. Just the breakfasts alone. Food doesn't matter. And what's tragic is that, of course, my patients go into hospital and they ask, do I have, is there a better breakfast? Because I have diabetes and none of that food is anything I can eat, because and they just say, oh, you just need to increase your insulin.
Right.
Yeah, just match it with your insulin, because there's nothing else. And that shows the whole thing. And thinking people find that very depressing. Very, very depressing.
I can tell you that there's a member of my family who had a heart-related procedure. I will keep it relatively anonymous, but I'll just say that they were put on a heart-healthy diet in the hospital. So what that meant in the hospital was the thing that they were trying to order again was salmon and broccoli, which they had before the procedure. But now that they were on their chart on a heart-healthy diet, literally, in trying to order the food, the answer came back, well, that's not high enough in carbs. This is literally the answer coming back. This is a diabetic patient. And same exact thing as you just mentioned. So they said, well, it's fine. The glucose is being monitored, so we'll just add insulin as needed. And as it happens, I was there, which is why I was like blown away that this was a conversation even happening. Because again, signaling to me personally, I'm going, it's 2025, 2026. We're past the point of understanding, or we should be, for type 2 diabetes. And if a patient at least is opting to, fine, don't force them. But let's say they're opting to be low carb. Why would you actually prevent them from getting a meal that would be...
Just to go specific for a minute, the Accord study, it should have finished there. So the Accord study was one where the hypothesis was that improving blood sugar control and getting it down by whatever means would lead to people living longer. So they took people with poorly controlled diabetes and they used insulin and drugs. And that, are you familiar with the Accord study?
I'm actually not.
All right.
Well, I should say
good.
Yeah,
that's good. So the Accord study, people can look it up, but there it is. The hypothesis is poorly controlled diabetes, we know, kills people. So you lose a third of life expectancy if you're poorly controlled diabetes type 2. So it makes complete sense to take people with poorly controlled diabetes and rigidly bring that blood sugar down, and they use drugs and a lot of insulin. That study had to be stopped after 2 years because of the cardiovascular deaths. That's why you need to read that study.
Well, yeah, you're right.
And it was a landmark study because doctors were shocked by this, because it doesn't make any sense. The thing we were taught to do was killing people of cardiovascular disease, and they were gaining significant weight. So that is really important, and it was stopped on ethical grounds. And so we learned, what did we learn from those deaths? Well, we learned that yes, you sometimes need insulin for type 2 diabetes because it can be an emergency situation where you have to get the blood sugar down. But using insulin is a last resort for doing that because there are consequences. And yet it seems as if decades on, what happened? It was a massive pharma-sponsored study. It was published and we were shocked, and then we forgot.
Was this published recently, or was this a while ago?
No. I'm guessing 2006 2000. That kind of, that's why you haven't heard of it.
Yeah.
But it's a landmark study, and those people should not be forgotten, the ones that died, because they taught us something really important about insulin, type 2 diabetes, and cardiovascular disease, which I know is a great interest to you. And the Accord study, amazing. Anyway, get us back on track now.
Yeah, so
I just couldn't resist because I thought you need to know that.
No, this is why we do a podcast of this size. So we're going to go back to the 90s. You have the dynamic of psychology now coming in.
Yeah, I think this is psychology. It's where it's at.
And you're starting to get a new perspective.
Yes,
I'm hearing, with Jen coming into your life.
Yeah,
with how you're approaching medicine. We're still a long way away from you approaching. In fact, I think I heard in a recent interview, just preparing for this, you yourself still thought through much of your medical career that diabetes is just a chronic progressive disease, like all of your colleagues.
I believed that until 2012.
Till 2012.
Completely.
Okay.
Because it was my experience of type 2 diabetes. So for decades, that's what I saw. I saw that I'd start one drug and then another and then another, and then drugs for the side effects of the drugs. The people would get heavier and become disabled. It was a very, very depressing thing to witness. In fact, it was so depressing. And remember, I'm senior partner, I'm the boss. So I actually found the whole diabetes, type 2 diabetes, and dealing with obesity so depressing that I decided I would have nothing further to do with it. So I was able, as the boss, to ask Dr. Simon Tobin was my junior partner, and I trained him, and I wanted him to take over the whole diabetes thing. Because I didn't want to have anything more to do with it. And how curious that I came full circle. But I didn't. It was depressing because I wasn't effective. It was depressing because I wasn't making a difference. And I hated seeing this progression. It's just so I thought something about it wasn't going well. And I withdrew and thought I'll do psychology. I was fascinated in ear medicine. I designed an actual ear curette of my very own, the Unwin ear curette, and became passionate about cleaning ears out and stuff. So I went off into the wilderness of psychology, anything but diabetes and obesity. So it kind of got worse, right? Because I just couldn't solve it. So I withdrew for a bit.
I have a question for you. While Sharon and I were traveling one time, we saw a sign I just love. I took a picture of it, used it in one of my presentations where it said, please don't feed the fish bread. This is in like Bora Bora, I think, because it gives them diabetes and then it becomes a big health problem for them, right? Just set it right there on the sign.
Yeah.
And I remember thinking at the time, this is a lot. I've had Peter Ballestead on as well. And when reading the science from livestock and so forth, studies that are done there, they can just state things plainly, like as far as what's happening with the animals based on what the diet is, in a very, frankly, more scientific way. Like they're not trying to work with people's feelings. They're just saying, when we add, this much more grain, you get this much more marbling. It's just that simple, right? That's straightforward. But at this time, we're talking the 2000s. You mentioned the Accord study was probably before that. You might not have read it by that point in time, coming up to 2012, I'm guessing.
No, I did read it because in the practice we debated it because it was shocking.
Yeah.
But unfortunately, although it left a seed of doubt in my mind, it didn't lead to any action.
Because, and correct me if I'm wrong, you're still like probably most doctors and going, well, managing it aggressively is not great, but what do you do?
Yes.
You don't think in terms of...
I didn't think there was an alternative because plainly you can't... You're right. There was a big thing, there's an assumption. When you're challenging people, you go for the belief and the assumption.
Right.
And there's a flaw, isn't there? So it's correct to say you don't leave somebody with poorly controlled diabetes. You don't. But nowhere did anybody say lifestyle or diet. So I was left with the idea that, well, we've only got drugs, so there's nothing else to do. And that just got shelved for 10 years under the idea of, oh, well, don't be too aggressive then.
It's so fascinating to me coming from the engineer's perspective, because I'm amazed. The ADA, American Diabetes Association, I was really frustrated with some materials they released from a few years ago. And at the time, part of my frustration, I'll concede, was that I had some family and friends that are on the other end of the spectrum with regard to diabetes, as far as they want to have reasons to engage with carbohydrates more. They see me as like the carb police, even though I'm trying not to be that to them. I'm trying to just explain the science and so forth. But they will regularly pull up material from the ADA and be like, oh, see, they've got, this is...
That must have been so difficult that you're not a doctor. So your family are looking at you and thinking, but what does he know?
Exactly.
Yeah, what does he know?
But this led me to go, I wonder how recent the ADA actually is, and I wanted to research it.
Yeah.
And I was curious because, how much was it connected with the food industry before? Like, was it, originating from there? No, actually, you go back about 100 years. It was founded by a group of physicians, and there were two kind of principal physicians that really sort of led the way. And you could read their materials today. And back then, almost 100 years ago, the diet they had,
low carb
the diet they were recommending, because there wasn't a bunch of pharma at that time, was relatively pretty low carb.
Yeah, it was.
It was pretty close to what would be a well-formulated low carb diet today, with some caveats, but definitely very different than what the ADA is recommending right now out of the gate, with this plate where like a quarter of it is your favorite carbs or something. Sorry to roll my eyes there, but it's just it hurts me because diabetes is a major disease of my family. Because we'll get into the full extent of it, but where I'm going with this is that I believe that these institutions, even if they're originating on the best of intentions, they allow for this level of entrenched thought. Whether they mean to do it or not, they allow for a lot of these concepts like, oh, well, what can we do? It's a progressive disease. I mean, even the Diabetes Association says that. You can read it right here. They've got materials that they've produced, right? And sure enough, today, 2026, only very, very reluctantly, and only at the very last of all of these groups did they finally go, well, low carb can be an alternative, right? But it's so begrudging.
Yeah, but it's a very difficult diet.
Right, but it's very difficult.
It's so difficult, as if, losing your kidneys or your toes or something isn't difficult.
Right.
It is a difficult choice, but actually being unhealthy, that's what I see in every clinic I do. I know what that means to my patients. And when it's put like that, when you're saying the pros and the cons, so yes, there's this diet, but what if your kidney function improved? What if your blood pressure improved? What if you could run up and down stairs? What if you could breathe better? Or what if you could wear fashionable clothing? That's the deal. So, people always say, oh, I couldn't give up bread. Oh, but you might end up giving up your kidneys.
Right.
So
you might be giving up.
Really? You can't give up bread?
So, of course, I'm now getting close in your timeline to where I know where things are going. You gave a very seminal talk that was the first time I was introduced to you. And I'm jumping ahead a little bit in the timeline, but you describe a patient.
Yes.
And the And is this what happens in 2012?
Yes.
Okay.
There were two things that happened in 2012. One was the patient. So at that point, part of the finance of the practice depended upon compliance, quite rightly, of metformin, the drug for diabetes. So we're kind of paid if you take your metformin, or we're paid to give you metformin, because that's good practice. I mean, it is reasonable to give metformin to people with type 2 diabetes.
Right.
And
just to level set for the people listening, I believe in 2012, metformin was kind of the biggest hotness. It was
the thing we used for type 2 diabetes, right. The drug we used. And we were incentivized to make sure that patients took their metformin, which is not wrong. The point was, one of my patients who I'd looked after for 10 years, I knew she wasn't cashing in her prescriptions, because we're fully computerized and had been for years, so we kind of know what's going on. So I knew that this lady was not taking her metformin at all. And so, as a good doctor, I write to her to say, I'm a bit concerned because I'm not sure you're taking your metformin. Please make an appointment at your earliest convenience. And obviously I'm planning to explain the risks she's running and so on. But the problem, when she came in, she was immediately hopping mad. She was immediately cross. She said, "You think you're going to tell me off about the metformin? Well, I've got a bone to pick with you." And it's to do with the fact that you've looked after me for 10 years. I took your metformin and it gave me diarrhea, but I was too shy to mention that. But I took it anyway because you said it was important. But why? How can it be that you never explained to me that bread was actually sugar, and that I could have eaten less bread and fewer cereals and less rice, and then I wouldn't need the metformin? She said, when you do my blood test, you think you're going to tell me off, but you're not, because my blood sugars are normal and they have been for months. And then she followed it up by, that point about starchy carbohydrates being sugar. Is that, how can you be medically qualified and not know that? That's actually schoolboy biology. It's not, everybody knows that starch is glucose molecules holding hands.
And what was your reaction?
I was scared. My first reaction, because complaints in general practice can run for years, and it was a valid complaint. So I was scared, and I knew she had a point. Also, she looked fabulous because she lost about 3 stone in weight. She looked really amazing. She was plainly looked like that well animal. So there was lots of emotions. There was fear. There was clearly I'd missed something. And also she just made a great point. I did actually remember vaguely that bread, that's vague though.
Yes, right.
Vaguely. Oh yes, there was that. And it was actually when I was about 16, we learned about that. So I said, okay, I've got stuff to learn. I'm listening to you now. I'm listening properly. And she was one of 40,000 people. Do you remember diabetes.co.uk?
Oh, yes.
In Charlotte. She was on there with thousands of other people, and they were all teaching each other how to do low carb, and they were all being scoffed at by the healthcare professionals, told that what they did was dangerous. And I was horrified by the unfairness of that my colleagues were vilifying them, people making an effort and improving their health, and then they're just told, oh, that's dangerous. Why have you done that? You should just take the drugs and not bother. It had to be wrong. So that's one really important thing that makes my mind was suddenly all these other things, and the sort of noticing of the people, the feeling that all these drugs, because I used to spend hours and hours just clicking, click, 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 click. That's me prescribing repeat medications to thousands of people. Hours, you're just clicking them all. And I thought, what am I doing? Highly qualified person. I just click, 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 all this. So there was that, and then there is another very important thing. Many of us have forgotten Dr. John Briffer. He was a young, much younger than me, doctor, and he wrote a book called Beat the Diet Trap, which Jen found in a discounted bookstore in 2012 at exactly the same time. And he was pretty accurate on metabolic health, insulin, and type 2 diabetes. And Jen was reading this book and she kept saying, David, you have to read this book. This is so important. You've got to read it. And it just so happened it came at the same time. Complete coincidence, those two things. So what the lady was telling me was so beautifully written in Beat the Diet Trap. And then the whole thing comes together. And then in January 2013, we started, Jen and I, with the first 18 people in the practice, learning with our patients in a collaborative manner. So I didn't really know any more than they did, but we all read the book. And we did it in our own time on a Monday night as a group experiment, in which Jen and I, we weighed ourselves and did it with them. And then the results, a bit like you've seen them, the result, like you've had like those moments, I couldn't believe what I was seeing, the improvements in the blood work. Some of it within weeks, particularly liver function. The gamma GT liver function dropping like people I'd written off for years with poor liver function was suddenly massive improvements. But improvements in blood pressure and lots of things. And then the hemoglobin A1C, the average sugariness, was truly astonishing. The whole thing was, I couldn't believe that. I thought, it has to be wrong. I have to have missed something. There's got to be something I don't understand. And then we had the data, partly because the partners didn't like what I was doing. They didn't like it. They felt that I was wasting time and it was weird. So I felt it was really important to get baseline data and follow up. So if you're going to do a thing like you do,
science.
That's what you could call it. We could call it science. If you're going to do that, you need that data, and I had it. So then I've got the data on the first 18 patients, which looks fraudulent because it's just too good.
Right.
Because the whole paradigm is drugs are the way to do it. And yet I was seeing an effect size bigger than I'd seen with many drugs. So I'm just thinking this cannot be true. And I think you've had time like that. It can't be true. It can't be true. And there's only 18. But then I had a sort of moral thing, which was, but if it was true, shouldn't I try and publish this somewhere? Haven't I got a responsibility to kind of tell somebody?
Up until this point, had you published much?
Nothing.
You'd never published
that's a lie. I published a paper in 2002 on the Unwin ear curette about earwax. But apart from that weird, eccentric thing, no, I had no idea about data. I had no idea about statistics, nothing at all, because I just run the practice. I had a bit of luck here. I remember I wrote to about 20 professors to say, hey, this thing's happened and this is the data and it might be important. One professor out of the 20 answered me, and that was Roy Taylor. Professor Roy Taylor,
right.
Who's very famous from Newcastle University. What a scientist, what a gentleman. And he said, David, this is important. The effect size is too big to be ignored, and I think you're onto something and you must publish it and I'm going to help you. He did the stats for me. And
so if you'd written to 19 professors.
But Roy Taylor got that work. That first paper was published, I think, about 2014 on just 18 patients. What's really interesting, the effect sizes I saw on the 18 were replicated later when there was 50 and 100 and 200 and 250. And now many other doctors around the world have replicated what I've done. Probably know Mariella Glant. Do you in New York? No? Oh, well, anyway. lots of other doctors have replicated this. So then the whole thing, so about 2013, we had the 18, I'm astonished. And they just looked like healthy animals coming back. Bright eyes.
Yeah.
Skin. Like proper healthy skin.
Yeah.
And people were saying things like, well, I don't think I need as much sleep. Or they were saying, I'm not as anxious. And I had loads more energy, a lot more. I needed an hour's less sleep a day. And I was so much more energetic and less fretty. Being senior partner of a practice with 10,000 patients, you get quite a few deaths, stuff happens. It's a very tough life. But I was coping loads. I had extra energy to do all this on top of a family life and the reserves. I had loads of energy, a lot more.
Let me ask a question that
Yes.
doesn't get asked a lot. Because this story you're telling me,
Yeah.
other doctors have had this story. And it plays out in the same way that you're describing, which is that they might have seen research, they might have seen books, they might have heard on the TV about a low-carb diet getting popular or whatever, but then it's a patient. It's like a pivotal patient.
Yes.
And not always the first one. Sometimes it's the fifth one or the eighth one or something like that. But you explain, and I totally believe this is true, that you had colleagues who weren't too happy about you doing it. You're now kind of making a departure from what is conventional medicine. You're going into this, whole new direction. And there's a lot of people don't know this, but even back then, 2012, there was concerns about, does that amount of protein hurt your kidneys?
Definitely.
Does the amount of saturated fat going to immediately put them at risk, even if they're...
Yeah, I got hate mail from dietitians telling me that what I did was dangerous and that would lead to vitamin deficiency.
Right.
There was lots of that kind of thing.
So once
sorry, develop your question.
No, so once you publish those 18,
yes,
do more of those colleagues who were first concerned shift gears and start adopting it then?
Very slowly.
Right.
Surprisingly slowly. Even within the partnership, that took years. And it required it required care, great care, because you're challenging people's beliefs and it's not comfortable to ask people to change.
And this is the thing that I think I underestimated when I was coming into doing this, is that in the world that I'm in, paradigms are rising and falling in months, weeks sometimes, right? Whole systems are scrapped and then restarted because engineering, we just know the revolution is always here and at the front door. And also, you don't want to be stuck in something that's going to become archaic in a moment's notice. And it's so different in medicine.
It really is.
And
so conservative, so...
And on top of that, there really is that sense that if you're challenging what has been somebody's medical advice for years or decades, it's very personal.
Yeah, it becomes adversarial.
Exactly.
Easily, and it's quite difficult. So I faced that within the partnership because I felt very strongly because I looked so good, but they were worried about what I did. And also quite rightly, they felt, well, this is using up time and energy, and don't we have enough problems to deal with in the practice? All of which was true. And so it was the graphs that started coming in then. That was the graphs. So if you look on Twitter, you'll see quite often I do graph of the week because I think it's a great way visually to show change.
Because people respond more to the visual.
I think so. It's a bit like, or before and after photo is better still. But within the partnership, I'd pop in their sort of in tray just for your interest. And it would be a graph, the falling off a cliff graphs that you see with weight, just like that. Oh, and another one. So I was just like dripping water erodes stone. I was just putting these, here's another one and another one. And then the other thing was my own health improved so much. And I think one of the things, my ability to run. So I remember beating at least 2 of the younger doctors in the practice in sprinting. And that shocked them because I'm doing this weird thing, but hell, no man likes being beaten by an old bald guy. It's just too horrible. And so gradually within the partnership, they went lower carb and then low carb. The midwife lost 3 stone in weight. So that's about 50 pounds. The practice managers low carb. It gradually spread, but it was surprisingly slow because it's a very painful thing for doctors. It seems to be uniquely painful for people it's the paradigm. We had the drugs are the main thing paradigm. And it seems, and the more senior doctors are, on the whole, not always, but the more senior you are, the more your experience and influence is to do with what you know about drugs. Well, the less inclined you are to say, but actually lifestyle might be better, because that's taking away your influence, isn't it?
I think it's really worth putting this in perspective too, because if you've only known this generation that we're in, you may not have the real sense of how truly new this concept is of your lifestyle is secondary to these drugs we can give you to deal with the outcome problems of your lifestyle, right? Like pharma, as we know it today, didn't exist a few generations ago or all the generations before that, right? So if you had a problem, whether you were talking to your priest or your spouse or your children, they would all see it as, well, this is the problem you need to solve.
Mm-hmm.
If smoking is a problem for your health, you need to quit. If drinking is a problem, you need to scale back, or you need to quit entirely. And a lot of times that wasn't even necessarily fair because there could be lots of other reasons, getting back to the dyslexia component, where you can't white knuckle it, right? But moving it over to this state where, hey, now any problem that emerges that can be solved with a drug, that's right where we're going. We're going to head for the drug to the extent to where we've developed this blind spot toward the lifestyle.
We have, and I think there's a sort of, going back to what I was doing, there's kind of a collusion between me with a 5-minute appointment.
Right.
What am I supposed to do in 5 minutes? And it was always thought that, doctors, the way we got people out of the room was by handing over the prescription, because then they know their consultation's over. So you see that to get it into 5 minutes, it's like, what's the problem? You need this, off you go. And the collusion is between a doctor who is tired, very pressed for time, and in my case, a bit depressed, and a patient who wants an easy fix and would quite like to carry on eating donuts. So there's a perfect collusion there, and neither of them want to break that because they want to eat what they want to eat, and I don't think it'll make that much difference anyway, but here's your prescription. And then what I did was stop colluding. And patients initially were very shocked when I'm saying, right, well, I think we can do better than medication. Maybe you don't have to take lifelong medication. I'm really up for it if you're interested in avoiding lifelong medication. We could do this differently. I'm quite excited by I think you'd do well.
And is this literally the beginning of when you start giving that multiple choice of 2 speech, or was that developed a bit later, past 2012?
Later, because my confidence wasn't great at the beginning, because I'd seen it 18 times, but wasn't enough for me to be sure. So initially I just actually, on the whole, I tried to just do people with pre-diabetes. So I was trying to keep it super safe. And then people with diabetes crept in, and then I got braver and braver every year that went by. And then in the end, I'm just about doing it with anybody. And I really developed the skills over years to do that. And so this sort of, do you want drugs, or shall we start drugs today, or are you going to change your diet? That kind of started, I'm guessing, about 2016, 2017. But I can honestly say since then, not a single patient, if I offer them, shall we start metformin today? You've got a problem. Shall we start metformin today? And you'll need that for the rest of your life. Or are you interested in doing lifestyle? Because I think that could really work well for you. You could be so much better in a few months. Not a single person has turned me down, not a single one. And bear in mind, the patients are allocated to me, and I'm not cherry picking the bright, genius, clever. We're just ordinary people. And that's what's different. It is possible for ordinary people. And ordinary people actually are intelligent, and they don't want to be ill. They're not that, they're not different to you and me if you just give them the information. And the information is, yes, you can use drugs, but there are pros and cons, and there are pros and cons to lifestyle. Which fits you best? Most of them don't want drugs.
And this brings it back to the signal, right? So they're facing doctor after doctor who has that collusion, as you described before.
Well, certainly I had a collusion.
Right. And it's not, of course, collusion could come off as a bit pejorative, but the sense is that here's a quick solution. And frankly, there's no other solution I see on the table.
Thank you. That's how it wasn't that I wasn't aware of alternatives that worked.
Right.
And I wanted things that work, and diet was a thing that dietitians did, and I'd probably refer you, but not talk about it. And I've said before that I did occasionally. So we were always being pressurized to give the latest weight loss drug.
Right.
Really, and I've had wave after wave of the latest weight loss drug. Loads of them. Amphetamines was one. There's been loads. And many of them got banned eventually or whatever. So that was one example where I did try diet, and this is what I tried. So you'd come in and see me, and you'd be a big guy, and you'd say, I'm going on holiday and I want to lose weight and I want the diet drug. And I'd say, no, I can't do that, but I've got a diet for you. So I'd say to you, right, you're going to have 2 pints of skim milk a day, and you're going to have 2 tablespoons of all bran. Are you familiar with all bran? It's a horrid breakfast cereal that's just bran, nothing else, fiber, right? And 2 multivitamin tablets, right? And I'd put you on that and starve you on it, because it more or less does the job. But guess what? Long term, it doesn't work. It just doesn't work. So yes, you'd lose weight for a while, you'd stick to it, but then you're so bored and it's such a horrible diet. But what happened was I always blamed the patients for that diet. And that's how I came to believe that diet didn't help, because I thought, well, plainly they're lying because they're gaining weight on this. They're not sticking to my diet, And of course, it was a terrible diet. And the person to blame for the poor results was me, not the patients. I was the common denominator, and I'd missed that I was the common denominator. I was just annoyed with patients. I'm annoyed with people who had an overweight problem and diabetes because they won't get better because they're just annoying. But of course, I was at fault, as my diet was a rubbish diet.
Right.
But that had led me into, well, there's only drugs then, nothing else, until the roof falls in 2012. And then suddenly everything, the idea of causation is so red hot, isn't it? Why? This is so interesting. And then it's all like the liver function, but why is that improving? Because it's really improving. So, there's this thing called fatty liver, and 30% of the entire population have fatty liver, but we never talk about it. We never talked about fatty liver in my practice. Well, I wonder why. So loads of why. Why did the blood pressure improve so much? Why did people's ankle swelling improve incredibly? Question after, why was their skin getting better?
And you touched on it briefly. Of course, it's another reason we both mutually love Georgia Ede so much.
Yeah.
But there's this unexpected behavioral improvement for a number of patients.
Definitely.
Right? And I myself, from doing my own experiments of coming on and off carbs for various ways to test lipids, unrelated, didn't anticipate how much some of the experiments, not all of them, but some of the experiments would have an impact on my behavior.
Yeah.
Sometimes it would make me irritable. There's this one story I won't go into again, but one of those times it kind of made me depressed practically for 24 hours. It was very weird. But I really gained a lot of respect for how much diet can actually impact my outlook and the way that I'm interacting with the world at large. And, I want to be a good scientist and say, I don't know how much carbohydrate reduction helps, every given person. I always qualify, I think appropriately, that it's not whether or not the person who's on a high carb diet needs to go on a low carb diet if they metabolize it well. It's just that there are a number of people, I'm one, you're one, for which we reach this state of not being able to process carbs in the same manner as we used to.
Yes.
To which we see benefit in just reducing the amount of consumption of them. And where do we go from there? Well, some people can improve to a degree with which they seem to be able to metabolize carbs better after being on a low carb diet or getting down to a certain weight and so forth. I seem to be one of those to some degree, but I really am always going to be mostly low carb in my life because I don't think that it's resolved.
There's two things in there that I'd like to pick out. One was going back to my life. So I thought drugs were the thing. Then Jen and I believed psychology was the thing. But then we were in for the third shock, which was actually, I could do CBT for a year on you, or even brief solution therapy. It'd take 12 weeks. And at the end of the 12 weeks, you'd be a bit better. Or you could go low carb and cheer up in 2 weeks. So we suddenly realized that diet changes reality. So we came to the conclusion. So Jen was in for a humbling as well. So I had the first humbling because drugs, whatever. Jen comes in, teaches me, come on, what are you doing? Psychology. And then the two of us, we both thought, whoa, you can refer unhappy, anxious people for psychology, or sometimes diet just sorts it out and they don't have a problem anymore.
Right.
And that was earth-shattering for Jen particularly, because her life is psychology. And yet she would now concede that very often diet trumps psychology and can change reality.
It's worth really driving this point home.
Yeah.
Because you're appropriately qualifying. It's not a catch-all. It's not a panacea. It doesn't work for everybody. But is there absolutely data that I've seen, that you've seen? There's so many people who have tried all kinds of medications to manage, and yet then ultimately found that diet was, and sometimes it requires a combination. Sometimes it's both diet and they still have to have some amount of pharmacotherapy. But do I personally know? Well, there's no wrong answer to this next question. Have you seen the film yet?
Of course I have.
Okay. So you of course know. I think one of the most talked about stories is Robin Dobbins and bipolar. She, was struggling with it for decades. Decades. And I myself thought until literally 10 years ago that, of course, bipolar is only manageable through drugs. I mean, full stop. There's no getting around that. Again, not saying everybody who's bipolar could go keto and then all of a sudden everything's fine, but do I now know, particularly since the movie went out, and there's been a whole bunch of people that have written in the comments, that have written to me directly, I'm blown away that there's so many people who've seen benefit.
Well, particularly in the UK, we've got Ian Campbell in Edinburgh University doing the RCTs on that. And the idea of nutritional psychiatry, obviously, we're friends with Georgia Reed. Fascinating. And I've so many patients who I've known for decades with anxiety, particularly anxiety, sometimes depression, completely change. But again, my own personal experience was I was somebody who was fretty. So I used to chew on stuff for days and worry. And there's loads of things within the practice to worry about. So I spent my time being very worrying. And then I found I just didn't worry nearly so much. And it's given me, I'm so much more confident. So I can do TV or radio or this with you or group consultations, none of which I was very anxious about group consultations at the beginning. And there was one thing that happened that really showed me this. So we had a wedding anniversary, Jen and I, and we went to a very expensive hotel, as you do. And the chef knew it was the wedding anniversary, so he made a special pudding for us. And it looked exactly like a lemon, but it was made out of really delicious lemon ice cream. And he'd made it specially. So you have to eat it, don't you? I wouldn't now, but I did. When I ate that lemon, it was like little fireworks going, sparkly things were happening in my brain. It was so delicious and the lights were all flashing on and off. Oh, this is fabulous. The next morning though, what a crash. I had a mixture of anxiety and depression. And it lasted for 2 whole days, that one pudding, the effect of it. And it's happened to me a few times where sugar makes me, and it's a mixture of anxiety and depression. You have a sort of, you're scared, but full of dread over nothing. It's my wedding anniversary. I'm having a fabulous time. I'm in a very expensive hotel, but by the next morning, I wake up feeling almost mentally ill. And it lasted until the next day. Wow. And that's happened to me. So one of the main reasons I won't have sugar for anybody, because it's just not worth it. And I've had plenty of patients who they do so much better. But there are good studies now, good quality studies looking at that. That's not really my thing. I haven't collected data on it, but I've seen plenty of very good examples in clinical practice. But Ian Campbell's your man, really, for the RCTs and the whole thing going on in Edinburgh.
I want to have him on. There's so many guests I want to have on. But I'd like to chat with him about it.
Yeah. But anyway, Georgia has to come first.
So by this point in time, you and I haven't met, but I believe it's 2017. 2017 at Low Carb Breckenridge.
Yes.
Is when I gave the talk that kind of was my breakout talk.
Yes, it was.
But while I'm there, I know most of the low carb speakers, but then you give your talk and you described exactly what you just did, but in particular, when you were describing what it is that you say to patients, and you were very soft-spoken, you were very, you just exude this kind of kindness. It's why it's almost jarring to hear you describe having to be in fights in school, because I'm like going, I can't compute this, connecting the two, because my first experience watching you live, I was so tuned in. You were describing the patient you just talked to us about. You were describing your initial connecting with diabetes.co.uk. And for people who don't know, it's a forum, but it's not just a forum. It's an organization. It's, I haven't kept up with it. I don't know where it's at these days, but just like your patient, me in 2015, I'm getting the same information from these forums where they're saying the same stuff, which they're saying, yeah, don't listen to the doctors, don't listen to the organizations, these institutions that are, like the ADA. Here are the results that we keep sharing. And I'm seeing post after post after post of people who are saying, oh yeah, finally, duh. I just need to bring down the carbohydrates. And it just computed to me. It made sense to me, right? Well, in this 2017 talk that you're giving, you're describing how when you approached, as a doctor, you approached diabetes.co.uk, you were really kind of the first seminal doctor who was just trying to reach across the aisle.
You've reminded me, you're right, because I'd forgotten that. But actually what happened was, so I saw online and I was horrified and thought, you need a friendly doctor. I am that friendly doctor. And when I went online, they immediately suspended me as a troll.
Right.
And the kids, thought it was so funny because their dad had gone I didn't agree with mobile phones, social media, any of that. And now dad's been suspended as a troll. And it's funny. But what they actually did was they came and investigated me because they thought probably I was a fraud. So they actually, the directors of diabetes.co.uk actually came to see me to check that I was what I said I was. They actually went to the trouble to drive all the way to Southport. And it was quite odd to be the senior partner of a practice being investigated. Who are these people to come and investigate me, So I was a bit mad because I'm offering to be friendly and helpful. But they were right. They were so suspicious of doctors at that point that they actually
it's an informed position, right? Look,
it was for a reason.
You experiencing this yourself, not just as a doctor, but as a patient, you can relate to how there's all of this advice for so long, but on top of that, a kind of dismissiveness, really just broadly across all of these medical professionals as to just how much diet really could matter for this thing you're struggling with that's, killing your family, it's killing you. So of course there's this backlash effect. There's a bunch of people. I definitely had a sense of that in 2015, 2016, when I'm like, what the hell? Why is there so much of this data accumulating now and there's not enough interest from these institutions that should care about this?
Well, it wasn't. There was two things, wasn't there? There was sometimes a lack of interest, but other times outright hostility. And it was the hostility that really, that made me wonder. Because I thought, well, I'm just doing my best and I'm quite proud of this. And am I supposed to put the patients back on the drugs or what? So what am I to do now? And yet I've made you angry. People are genuinely cross. And I was a long time working out why were otherwise reasonable professional people cross with me for something that I was quite proud of, because I thought, well, hey, I've done this thing. It's good. But no, that's a bad thing. We probably both had that experience of we'd broken some kind of rules, but I didn't know what it was I'd done. I just thought, that's good news, isn't it? Weird.
So jumping back to 2017, where I see your talk, at a certain point, you're getting interviewed. I don't know if you remember this moment. I remember very like it was yesterday. You're getting interviewed by, I believe, Diet Doctor at that time.
It would be, yes.
And you're going out as I'm about to head in.
Yeah.
And I said, Dr. Unwin, I just have to tell you, your speech was amazing, and I'm an instant fan of yours. And I'm going to get emotional saying this. And you were like, I'm an instant fan of you.
Yeah.
I was like, oh, wow. This is just, I'm walking on sunshine.
Yeah.
And that's why that interview, when I'm walking into it, I'm just in such a good mood.
Yeah.
because watching your talk, I just felt transported into the moment. And I remember thinking, and I've said this, by the way, many times in the podcast and other episodes, I've said, by golly, if I was in the UK, I would just be praying for Dr. Unwin to be my doctor. Just because just the way that you described it and the way that you laid out those choices, getting back to the signals, you're signaling to the patient, I'm with you. I'm with you. Yeah. I'm here for you.
There's something really essential there about, so I'm actually a Royal College of General Practitioners national champion for collaborative medicine.
That's a mouthful.
Yeah, isn't it? But it means that I believe absolutely in partnership with patients, and I believe that you get better results, and I believe it's better for the patient and better for the doctor. Because the alternative is authoritarian, where I'm the expert and you just do as I say. But that's a very empty experience for both of us. And also, when it goes wrong, you just cross with me and you get a complaint. Whereas if you and I discuss together the options ahead of you and you jointly with me choose that, you're far less likely to get a complaint. And also, the experience of medicine is completely different if we do this together. Completely different. Marching in, it's magic. It's really lovely medicine. And I used to think that it would take a lot more time. So that was my excuse for not doing it, if you see, because how am I going to do that in 10 minutes? What I realize is if I can give you alternatives, choice, and if I can give you hope, then you're going to do a lot of the work yourself. So that we too quickly tell people what to do before we've intrigued them enough and made them think about hope. And if you give hope first and a bit of physiology so you understand what I'm saying, then you'll read the leaflet. Because then, particularly somebody like you is just going to go away, read the book, do the thing. But I've got to give you hope first. And it's got to be that feeling of you're an equal partner and you are actually responsible for your future. I think that's key. I like the idea that each one of us has a series of possible futures. It's got to be true, hasn't it? There's the one where I give you drugs, or there's which one are you going to pick? And with every little bit of decision you make, they add up to your future. I mean, there's random bad stuff happens and random good stuff. But these things about interesting people, and there's this idea of wanting you to pick your best future. Would you be a partner in that? Because I'm interested in how could you get your best future. And that's collaborative. Becomes we. And it just feels right. And it doesn't necessarily take a lot more time, because once you're motivated, you'll go away and look like you have. You're prepared to read stuff, you're prepared to experiment, but you have to believe it first. And of course, feedback comes into that a lot, doesn't it? You're the king of that.
Oh, yeah.
I think that's what I found fascinating about you was the way you've used feedback, the way you've looked at, but what if it changes? Oh, it has changed. Can I replicate that? That really interested me.
In software engineering, over time, there have been broader methodologies of getting stuff done.
Yeah.
And the older version is known as waterfall. Waterfall is you do a lot of planning. And then, after all that planning, you finally go to execution, right? Big plan, big project of execution. Over time, there were methodologies called lean and variations of lean, where It's much more iterative. You're recognizing that's just not how the world works. You can't be that good at anticipating all of the things in the future. And we also just don't work that way as humans. As humans, we learn a lot as we go.
Yeah.
And that's okay. You build that into the process. And you just say, that's fine. Let's do a trial. Let's do like a little tester, a little period of time. This is how I usually approach it with my family and friends. So I'll say, look, I know you keep looking at me like I'm a health nut. I swear I'm not a health nut. I still have, my thresholds of what I allow for. But you're telling me you're struggling a lot. Your blood work doesn't look that great right now. What if we just take it? You pick the moment when we start. Let's see if we take it. And then for 30 days, you could do anything for 30 days. Just do this diet for 30 days. I'll be with you the whole way. And on the 31st day, you can have whatever you want. But it'd be great if you could hold off until we get your 30-day blood work and you see the 30-day blood work. Because then you will have completed an experiment. And usually I find that when I pitch it that way, not only can they feel like it's something they can do, I tell them, now turn that into a pitch to all of your friends and family who are going to be bringing around stuff, because you can say, well, I'm doing this experiment. Dave's making me do it, but I'm kind of interested in seeing how it goes. That's iteration. And so yes, with the blood work, with my experiments, yeah, I didn't think then that metabolic markers taken once per year, given just how much I would see just with my glucometer. I kept going, now wait a sec, this has ramifications on all kinds of stuff. If it changes this much hour to hour, why would I get my blood drawn once a year? Like if I ate something weird 2 days ago, would that have an impact on my blood work to this morning?
Yeah.
It does.
All of that was amazing to me because, of course, it's true. And I'd never thought about it. Never thought about the variability. But it's similar, isn't it? Like blood pressure. You don't have a blood pressure. That's the idea of your blood pressure. Like it is a figure. 140/80 is your blood pressure. That's nonsense, isn't it? Because every beat of the heart, probably the blood pressure is a bit different. So it's changing, and then you're scared or whatever. So when I sat in the audience, I was suddenly thinking, yeah, this is like blood pressure, because I'd previously come to see blood pressure in that same way, that we treat blood pressure like an absolute thing. And I did an experiment that I haven't talked about before, which is interesting. So on a hunch on blood pressure, because I thought, well, for patients, they seem to be very anxious about their blood pressure. So, and what often happens is they see the pharmacist who says your blood pressure is very high, and they're going, how high? Oh, very high. You need to see a doctor today. So and I'll just check it again. It's worse. And people rev themselves up, and then they come to see Dr. Unwin. Oh God, the pharmacist says my blood pressure is sky high. And that happens a lot, So that started me thinking about, and then you admit them to hospital, and then sometimes it wasn't a problem. So I took 100 patients, and I took their blood pressure in a different way. So I do the first blood pressure. So I'd do your blood pressure and I'd write it down. And then I'd say, right, you can get a more accurate blood pressure reading if you'll do a little bit of breathing work with me. Just take a deep breath in and let it out as slowly as possible. Just let it out very, very slowly while I'm doing your blood pressure. And you're going to do that. So take a deep breath, let it out as slowly as you can. And then when you need another breath, take one. And then meanwhile, I'll do your blood pressure. And I discovered that the differences between the blood pressure when you came in and the blood pressure after 3 of those breaths, you can work out the average. And it was, I think the systolic was something like 18 millimeters of mercury lower and the diastolic 9. So it makes a nonsense of the idea, the concept of treating a blood pressure of, you need to give drugs if it's more than 150 over 90 or whatever. It's a nonsense because it's dynamic. You're dealing with a dynamic situation. So the judgment about treatment depends on lots of things. It's actually far more interesting. So when I heard you speak, it fed into this. I'd never told anybody about that work. That was just personal curiosity. I didn't publish it. I did that years ago. That happened before the low carb thing. I was just suspicious about this. So when I heard, I thought, oh my, this is just like the blood pressure thing all over again, and I missed it. Because why? How can it be that my cholesterol is fixed? It just can't be.
It's so not.
Yeah, exactly. Or blood pressure, or this. We're in a wonderful. This homeostasis is so wonderful and balanced and lots of things. So truly, I remembered your talk because then the blood pressure thing was in my mind, and all sorts of other doors began to open about, what we've got is an adaptive system. Homeostasis, it's adapting to things, reacting to things. It's not just is. It's a result of other things, and you were illustrating what they were.
Which, I mean, again, it's kind of, I had a friend who was a PhD who said, you really should go the Dr. Bernstein route and consider like becoming a doctor. And I was like, oh no, it's like, but there needs to be more engineering thought process in the field of medicine. I go, well, the obvious answer to that is you just need more doctors to be engineers. You just need more of this mechanistic thinking to show up in more of these CMEs. It doesn't need to be from a Dave Feldman. It can be from anybody.
Yeah.
But take one of the experiments I did in 2020, I want to say, and I put on my blog, but I never publish it. I should publish it someday. Is I pulled out the PTS diagnostics and I was taking my blood 6 times a day. So I got my lipids 6 different times. I got it when I woke up. I got it 7 a.m., 9 a.m.
How did you pay for all this?
It's like $10 per strip, so it's not cheap. But
because that's what I thought. I thought, wow, how has he financed all those blood tests? Because in the UK, private blood tests are very expensive.
Right.
Really. So one lot of lipids and doing it carefully could cost $400.
Well, it wasn't a full blood draw. It was PTS diagnostics. What it is it's like a glucometer, except that you have to get more total blood volume. You get them through these capillary tubes. So I've got to get the capillary tube out. I've got to like squeeze enough blood that it fully fills it.
Did it not hurt?
Oh yeah, it hurt.
Because that's the other thing. So I love continuous glucose. I've got one on now because it stops all this constant breaking.
Right. But tracking lipids, that's difficult. But it showed these cascading events. It would start lower after I was 12 hours fasted. But upon waking up, my LDL would be, the LDL would increase until I ate, and then it would dip down. Why? Well, it's not just the lipid energy model, it's basic physiology, which is that as the fat's coming in, it's coming in with a modestly higher amount of a bolus of insulin. So lipoprotein lipase is picked up, and now it's storage time. So more of it's going into the fat cells as well as other tissues, right? But then you'd slowly watch it start increasing again. We're talking LDL, right? LDL cholesterol. So I want to grab all my cardiology friends and my lipidology friends. I want to get them all in this room, and I would be like, look how much I'm going up and down by tens of milligrams per deciliter over a 24-hour period, and that it's repeating. It's not random. You can actually watch in real time this physiology
Had it been
play
documented before? That's what I was thinking. Were you actually the first person in the world that knew that there were these rhythms? Had it been documented before?
I think that so. There definitely are studies where they do variations of fasting individuals. We have many that are cited within our lipid energy model paper. And they've done other variations of where they've tested people's lipids through the day, but it wasn't in a typical it's usually for some kind of intervention or something to that effect, right? It is actually possible, and it would make it even more embarrassing that I hadn't published it to this point, that may have been the first time there's been repeat testing in an otherwise the experiment itself. The basis of the experiment was that I was testing a feeding window difference. So I have a baseline meal protocol that I've reused through several experiments. So it's the same 3 things. It's very boring, but
because it's an n=1 that's so important and so interesting.
It's an n=1, but I'm very adamant about that baseline diet and the timing of when I eat and the timing of my exercise and the timing of my sleeping all being the same. And if it is, in theory, if the lipid energy model works, then the pattern should repeat, and they did. So my baseline diet is over 10.5 hours from first bite eaten to last bite eaten is roughly about 10.5 hours, right? The feeding window experiment had another phase that was also, one was 5 days long. The other that was 5 days long was 4.5 hours from first bite to last bite. And what I wanted to see, as I was expecting, was that the area under the curve for LDL would be higher in the feeding window that was shorter, even though the food quantities were identical and the food composition was identical. It was just compressed. Those 3 meals in the longer span compressed down meant that there would be higher area under the curve of cholesterol. And so if you think about this should apply even with a mixed diet. If it does apply with a mixed diet, then in theory, if this was the lipid hypothesis, people who were doing intermittent fasting would be at higher risk because their LDL particle count would be higher, which I would argue is because they have less insulin under the curve to match the reason why there's higher LDL cholesterol area under the curve. Because a higher period of time of fasting means you're powered more by those lipoproteins directly. Now, it may be a modest amount of an increase of LDL if you're like on a higher carb diet. But from a common sense perspective, do you yourself think that probably people who are intermittent fasting are putting themselves at greater risk of heart disease?
I think it's very unlikely because, so one of the guiding principles for me is looking almost through the paleo lens.
Right.
Because I've become really interested in what did cavemen eat. Partly because I sat next to at dinner one day Mickey Ben-Dur, who is an international expert on what cavemen eat, and he's been scraping the tartar off cavemen's teeth and all the rest of it. So, but basically the point is that most of our physiology dates back to our origins as cavemen and women. And so it's not likely that they got to eat really 3 regular meals a day. It's very unlikely. And in winter, they almost certainly, how would you possibly? I think a degree of fasting, we were designed to tolerate fasting.
I would almost want to say, getting back to the cavemen, our environment designed us.
Yes.
Right. So in other words,
yes,
we have, it's expected that we have subcutaneous fat late in the game.
Yeah.
Because we had to develop it so that we could handle this scarcity of food.
Yeah, that's a great way to put it. So I'd go one stage further. We're the result of a world that no longer exists, unfortunately.
Agreed.
We live in, so we were designed for the environment of a caveman and woman, because that in time has just been so much longer than we've been in modern life. We're poorly adapted to the diet and the way we live now. And so many of the problems I feel are to do with our struggles, psychological as well as physiological.
I couldn't agree more.
To the way we live, and it's, as far as I can see, it's getting worse and worse.
I couldn't agree more. It's definitely coming at it from a programming standpoint. Evolution. We have evolution in software engineering with regard to. Have you ever heard the term legacy code?
No.
So the concept of legacy code is you have the first generation of, let's say, Facebook. It's a platform.
Right.
It's got a lot of code that built it. Guaranteed, it has new iterations of what Facebook is. Now, the engineers of Facebook know where they're going. They know the UI, the user experience. It needs to look a lot the same. They're not going to replace the whole platform overnight. What they're going to do is they're going to have this service replaced. They're going to have this module replaced and so forth, right? So it's actually a kind of evolution that's happening over time, but it's informed. It's informed because it's informed by what people are using. That actually was very relevant to why they changed the UI, the user interface. They saw this button gets more use. Now we need to put it up higher and over here. That way more people can use it. That's evolution. By the same token, the many different iterations of us, the person who had a six-pack year-round, they're gone. Because guess what? When winter hit, the ones who could pack on some weight, they lived through that winter.
Yeah.
Six-pack guy is gone.
Yeah.
When I'm chatting with women in my family, and they're fretting, I can't lose weight like the guys. I'm like, that's because of evolution.
Yeah.
You're carrying the engine of life.
Yeah.
I'm sorry, but it makes perfect engineering sense as to why your ancestors, the one that made it, were the ones that could carry the baby for that long, right?
That's exactly what our family say about Jen. Because she puts on weight more easily than me, but she would have lived through the winter. I'd be dead because I'm a skinny guy.
Right.
And what happened to me, but she's been designed perfectly to have children and reproduce and survive. I have another concept to bring in at this point, and it brings me back to the nature thing. So sometimes I think about this whole human thing is, if you were going to keep a human being in a zoo, as we keep tigers and other things, you'd have to work out what is the perfect way to feed that human being that you're going to put in your zoo, because you want them to be happy and you want them to live a long time. And that's what I'm often thinking about, is if you had if you wanted them to thrive and do well, and that's what I'm kind of working my way towards, is this idea of what's the optimal human diet? What is it? And it makes sense to me that it's something to do with the way we were designed and the way we lived. And we've got to reinterpret that for modern man, because that world has gone. And what we're trying to do is get the nearest approximation we can for how you would keep your pet human and have them thrive.
I put a qualifier on it, though.
Yeah.
We are designing an environment. We're definitely designing food. We as a species are designing food that's hitting some ancient wiring.
Oh God, yes.
That's meant to fatten us up.
Yeah.
Whether we mean for it to work this way or not, our biology is playing the longer game than we are, getting back to the fattening us up. I believe that is why what is sweet is very exciting to us.
I agree. It's to do with our hard wiring.
Exactly.
And we're defenseless against excess carbohydrate consumption because it didn't exist in nature, or only in autumn when you wanted to get fat anyway. So that evolution never anticipated the way we live now, which is a surplus of carbohydrate year round.
And I think the refining is a big component of it.
Yes.
Because before we had access to protein, fat, but usually fat if it was from animals, typically, and very, very fibrous carbs compared to today. Like it's not even a close. The fruit of today is a far distant relative compared to, what their ancestors were as well, right? There was, in a recent podcast, I was hearing you describe bananas. How'd you describe bananas?
A sugar stick.
A sugar stick,
probably.
Yes.
It may have been that.
And if you were to go back to a banana from 100 years ago, it wouldn't be, right? It would probably be. It still have a lot of carbs, but nothing near compared to. First of all, it'd be much smaller. I believe that the original bananas were much smaller. But take pears, oranges, all of those. They were way more fibrous.
Yeah, or even in recent times, they've even made tomato. I've got a friend who is kind of engineering tomatoes, and they've added they breed tomatoes to be far sweeter now.
Wow.
Far sweeter.
Wow.
I mean, times several 100% sugarier now than they were 15 years ago, particularly the little cherry tomatoes that we all like. So yeah, we are, I agree with you completely. We're defenseless against excess sugariness, and we're hardwired to pursue it because throughout evolution, you probably survived the winter if you sourced that stuff. And now we don't know what to do about it, to the point where the answer is bariatric surgery, or the answer is GLP-1 drugs to try and help us live in the modern world.
Which brings it all full circle, right? Is we are smart enough to know these biological signals. We're at a state of human evolution enhanced by AI, information technology, to where we're fully aware. Getting back to the zoo animal, if you're designing your diet for yourself, right? Let's say I'm going to check you into the zoo. I'm going to be like, David Unwin, you're going to spend the rest of your life in this. What would you like to choose to eat that you believe will give you a happy life, right? And I think if you knew that you didn't have control, you'd probably choose a healthier diet knowing that you wouldn't have control. But let's say instead, your cage is a typical supermarket. And now you have access to both good and bad food, right? I think most people in today's environment, they would have the same struggle as so many others do, which is that you can be aware that the food you're eating is not the best food. You're making a conscious choice to eat food that you yourself have a low opinion of, right? How much is it still keeping you from doing it? And that gets back to that whole psychological, the whole behavioral component, right?
So as I would often say, when you have intelligent people doing stupid stuff,
right,
you have to remember nicotine and alcohol, and you have to think about food addiction, which is something that Jen and I have concluded is a very serious problem, because in the practice, so we were getting back to 2017, 2018. By then, we know that about 50% of everybody that goes low carb is going to achieve drug-free remission of their diabetes. So they're going to get a hemoglobin A1C not in the non-diabetic range, and they're not going to need drugs. So we knew we could do it for at least 50% of all of my patients that choose low carb. But then what you find is they know how to care for themselves, and yet they start going back to the carbs. Why do they do that? And so I've got an example I have one patient who it was so bad he had an amputation, which is quite common. Then we go low carb, and he gets drug-free type 2 diabetes remission. And so you would imagine that person knows that the consequences of giving up that diet is amputation. And yet still, that person goes back to eating carbs. Why? And then I had another patient that changed everything. This is a man who's given his permission for me to describe this. So this was a patient. So now I'm getting into, it's okay to do a good thing, but maintenance is the holy grail. Because it's pointless if Dr. Unwin does this thing if people won't maintain it. So I've become really, really interested in how do I improve my data, a bit like you probably. It's an iterative process, just like you say. I want to work out what works and do more of it. But I'm also curious about what fails and why. That's interesting too. And this one patient I'll tell you about. Or did you want to ask me something else before I tell you?
Go ahead and do that. I want to remember the one point I was going to make with regard to the trial period, but go back to that.
Right.
Go ahead.
So here we are. We're monitoring the patients in the practice the whole time for how they're doing maintenance, because I can do that because they're my patients till I die or they die. So I can do blood tests when I want. It's something you can't do in the States. It's completely different, this idea of they're my patients.
I mean, you can. Sorry.
All right. Yeah, that's fair.
Please continue getting your blood work. You
can.
Anyway, okay.
Right. So this patient, and a very intelligent person, he runs a successful business. So he's bright. He's got a problem though. He's very heavy and he has poorly controlled type 2 diabetes. These two conditions, his weight and his poorly controlled diabetes, are stopping him from having very serious surgery that he needs. So I'm really trying hard for this guy because he needs bilateral knee replacements because the pain is so great, he can't run his business and it's all unraveling. I'm trying everything. I know initially he responded to low carb and it went well, but it didn't last. I couldn't get him through surgery. And I'm trying everything. And then, so first of all, low carb, then I added a continuous glucose monitor, and that helped a bit, but I still couldn't do it. Then his wife comes to see me and she says, Dr. Unwin, I'm going to level with you. You need to understand his problem. And I need to tell you this. So she said, we know that bread is bad for him. So I would always, at the end of the day, if there was any bread, I'd put it in the bin before we went to bed so that there was none left around, because he was in the habit of getting up in the night and eating the bread. He would get up and go through the bin and eat the bread out of the bin. So she's an intelligent, resourceful woman, so she puts liquid detergent on any bread. But still, he eats the bread.
Whoa.
Yes, yeah. And she said, I was surprised too. So now she said, what I do is I spray bleach on the bread and leave the can of spray bleach by the bin so he knows don't even bother because every bit of it's got bleach on it. And she said, only bleach will stop my husband from eating bread. And that's the best way I have of helping you understand ultra-processed food addiction. Because that intelligent person does not want to be ill. He needs surgery. He can't run his business because he can't walk well for his knees. So he had every reason to do well. And his wife was trying to help him. But the addiction was so bad that unless there's bleach on his bread, he'll get up at 4 a.m. and eat bread. And that explains, I think, how some people are so driven, and it's like cigarettes. People know, who doesn't know that cigarettes give cancer and you could die, and yet they're still smoking, aren't they? So something is more complicated going on, very complicated and very difficult. I did sort out that patient, by the way.
Oh, good.
Yeah, we did. So he's had his operation, he's fine.
Why I was going to bring back the trial period is I was going to finish this point. Part of what I'm trying to position it as to the other person so that they don't think that the diet, because usually I am pressing them to try, like, say, carnivore or something like that, be hardcore for me for this period of time, is I know that data often does a job I can't do. when they see their own blood work in
Yes.
30 days,
Seeing is believing.
it's there forever.
Yeah.
They now have forever this benchmark that they saw could happen, because a lot of times what happens is people go, I've tried it. I tried X diet, or I tried Y, exercise or whatever. They've convinced themselves that they did the best they could on trying to do fill in the blank, whatever it was. And as, in the same way that you're doing, I'm saying, hey, I'm here with you. I want to take you through, I at least want to take you through getting to this data. I think it'll change your opinion.
Yeah. I've got something to add to that. I think there's something else you can do as well. People vary. So some people like graphs, some people like data, but other people are more susceptible. So I'm always trying to get better results. So I'm always curious about something else. Now, something that Jen has taught me is the power of noticing. And that is, so I would also say to you, right, I've got your blood work, but before we discuss your blood work, I want you to tell me how you're feeling and anything you've noticed. And then they say things like, well, it's weird because I'm not hungry. Are you sure? Other people, yes, I'm definitely not as hungry. Really? How interesting. What else? Oh, I've got more energy and I'm not worrying as much. So I'm getting people to notice and verbalize things. Has anybody else noticed anything? Yes, my wife says, whatever. So there's extra value, not just in the graphs and the data, but there are some people who are more convinced by their feelings or what they've noticed. And it's really useful to get them to notice that, because then when later they maybe go back to carbs, you can say, do you remember how you felt that day you came to see me? And they say, oh yeah, I had more energy. Well, why don't you do it again?
Yeah.
Just asking. You did it, so you could do it again. And I think if you add people's own feelings to the graphs, I think I'm going to get a better result, because that's really what I'm about, is what's the best I'm interested to see what can the British Health Service, with 10-minute appointments and no money, what can we actually achieve with lifestyle? It's like a giant experiment for me.
There's me personally, I also think that there's two things that I learned both in my experiments and also just working with this, is two things that I think are the most underestimated, in my opinion.
Mm-hmm.
Proximity. The closer you are to the problem foods, just the more likely you will be to give into it. This is again, getting to all kinds of substance abuse, right? You get yourself far away, you make sure it's not in the house. Ideally, you're not in a food desert, so you're not just surrounded by all of the things that tempt you. If you can get further and further away, the more distant it is, the more it doesn't weigh on you as much.
Otherwise, it's calling to you. So if that cake is right in the refrigerator, it's calling, eat me, So it's about planning for success, but that's a very serious business. So the number of people that say to me, "We've got that in for the grandchildren," come on, who's going to really eat the biscuits? Right. Who's going to really eat those biscuits? And also, if you really love your grandchildren, is that the best way to show love? How about attention? How about fun, storytelling, or travel or something else? But that you would not believe the number of people that seriously, I say, have you got biscuits in the house, cakes, what's going on? Oh, we have our so-and-so come, the grandchildren. And it's about seriously committing and planning for success.
And I think all of us, and I definitely include myself, you don't realize that it takes energy to resist when you do have that level of urgency. There are certain foods that I learned could be low carb if I didn't eat them all day long, but that I can't trust to keep in the house. a good example of one of my favorite go-tos is I really loved no sugar added dark chocolate covered almonds. And
I would too.
And if I ate just the serving size, which was 9 at a time, I'd be fine. But here's what happens. I'll get it from a Sprouts. I'll even check my blood, after I've eaten it, hardly any change at all. I measure out the 9, I eat it, and then I'm like, okay, back to work. And it's there at top of mind. It doesn't leave.
They're calling to you.
Right. They're calling to me. And this is another thing that I noticed that I'm excited to chat with your wife about, which is me being me. I see there being 4 stages of this addiction effect. I won't mention the first one, I'll come to it last, but the second phase is the plan that I'm going to eat the food that I know I shouldn't eat. There's a dopamine hit just in having the plan.
Definitely.
There's like you know what? I'm going to give in.
I deserve this.
And and I'm feeling good even before I have it. And part of how you know it's an addiction is you go to the place of the thing that you're going to get and it's closed.
Yes.
And that doesn't change your mind at all. You just go, well, I already made the decision. So now I'm going to go across town or I'm going to whatever. Then there's the consumption of the food itself, which of all these 4 stages is like the shortest one. The
Isn't
consumption.
I agree.
The food itself.
And and the joy from it is fairly fleeting.
The aftermath, that seems to always be like at least a couple hours.
Yeah.
There's I did it. Yeah, I shouldn't have, but God, it was so good. It's such a present memory, right? Even if I'm like working on spreadsheet and stuff, I'm like, yeah, I enjoyed it. Okay, so let me get to the first stage because this took me a while to figure this out.
Yeah.
The first stage isn't the plan to eat the thing that you knew you didn't want to eat or you knew you weren't supposed to eat. The first stage is the release of the indecision. So when you're waffling, that's the exhaustion. Like, I know the thing is in the kitchen. I wasn't going to eat it. I committed to not eating it. That's supposed to be for, my wife or my sister or whoever it is. And my energy is draining by, I could eat it, but I shouldn't eat it. I could, but I shouldn't. It's the point where I go, whatever, you know what, I'm going to have it. Or let's say my friends and I are going to be going to, a restaurant or something, and we're trying to decide which one. And there's a thing on the menu that's not on my diet. No, I shouldn't. But I haven't really committed to it. It's still a possibility. And while it's a possibility, I'm in this teetering stage.
I get that. And it's tiring. And that's why it's easier So in the early days, I wasn't as extreme as I am now. And the reason I am now sticking to it is just less tiring.
Exactly.
It's just less tiring.
Right.
And to have a little bit, that's tiring because then you want more, or to wonder whether I shall have it or I shan't have it. I've just finished with all that. But that happened for the first year or two, all that messing about. It took me a year to get off biscuits, a whole year, because I was in the habit of having biscuits to cope with being a doctor, and they were in the drawer. So will I have a biscuit, or will I have 5, and it took me a year of messing like that. And then in the end, I came to the sort of cold turkey thing. I thought, I just need to stop this messing because life's too short for it. It's just simpler for me to say that is no longer food. And I've stuck to it very well. I haven't eaten bread a tiny bit for years and years and years because it's just easier for me not to.
And so this is comparable to genuine sobriety.
Yes.
You say, not at all.
Yeah.
It's not going to be in my life.
Yeah, it's just easier to be in that. I think it's also to do with the value of habits. So when you get into good habits, that doesn't use energy. So brushing your teeth doesn't use energy because you always brush your teeth, so you will. You don't have to wake up and think, oh, I must brush my teeth. So getting into an exercise for me is another one of a good habit. And then my diet is on the whole a good habit because it uses up less energy. and it's more efficient. And I don't need self-control, because otherwise once you start, I do eat, I don't eat, then you're the white knuckle ride,
Right.
which is trying to control, and then you're disappointed because you didn't, and you go through this ridiculous fandango, and I've had it with the fandango.
There's this other factor, which is that I'll often describe it for the things that I know are going to be problem foods. Like take the dark chocolate covered almonds. If I went to a friend's house who happened to have them, for example, and might be like, "Oh, you like these, right? Would you like them?" I would likely respond in the same way that I do French fries. For all of my carb swap experiments, I didn't touch French fries because I treat French fries as like an alcoholic would treat alcohol. I'll say this, I've said this before, and I'll say it again here. If I have some French fries, I'll have 1 million French fries. What I'm seeing in front of me is not where I'll stop. I know that it'll be a long, long ride until I finally get done eating French fries. So I have to look at the fries that are in front of me as not something that's portion controllable.
Yeah.
I
reclassify them as not food.
Right.
So I can look at it, it's not food. It's not, for me, it's not a thing I eat ever for that reason.
And that helps you stay cold turkey.
Brilliantly, yeah. And they don't call to me as much. Now, Jen says that I am a harmful user, not an actual true addict.
A harmful user.
A harmful user. So I can actually control myself with struggling and the white knuckle, but a true addict would struggle even more than I do. You'll have to ask her about that. But she says, David, so she is a true addict. And the difference between us is that, so in the early days, if I broke the rules, then it might take me a week to get it sorted. So we have a holiday, we come back, and it takes me a while to stop the messing. Maybe a week of I'm not, I'm having a bit, I go back, whatever. But Jen, it could be 6 months. It could be 6 months. I remember one Christmas, the very early low carb Christmas, and we thought, well, why don't we just have one day? Why do we have to do this, and the family and everything? We've got kids. So we'll just have Christmas and it'll just be Christmas Day. Jen didn't actually get control till well into May from that. And I watched her and she said, it's Monday. I'll stop on Monday, procrastinating, Monday. And it took me a week, and then and then we're having arguments because I'm saying, what is going on? Just stop it. Or I'd start throwing away things that I'd find. And then we'd have arguments because you've no right to do that. And that's the difference for an addict. The consequences of slipping up can be months.
And unlike drinking and smoking, part of the problem is that we do have to eat.
Quite. Yeah,
so
that's right. So that's quite a problem. And also for a mother, she has to produce food for the family, and she's involved in the shopping more than I am. So interesting.
I compare our food environment, the present food environment, to smoking a lot, because smoking 60 years ago, 70 years ago, smokers would concede that they know it's not good for you, but it was minimized. It was like, I know I probably shouldn't smoke. It's not healthy, but it wasn't thought to be.
No, I remember, so there was a doctor in my practice who advocated Marlboro cigarettes for stress. So he would, I have patients living now who say, I smoke. His name was Dr. Lamont. So he died. He was my patient. He died years ago. They say, well, I'm still smoking. When I was a young guy, I was so stressed, and Dr. Lamont actually gave me a cigarette in the practice.
Wow.
So he handed over, he said, well, I use these. And it took 30 years for doctors to catch up with cigarettes properly. 30 years for the whole cancer thing to come. And Dr. Lamont dated from when it wasn't. They were thought not that good, but they were thought okay for stress because he was handing them out to patients.
I mean, quite literally, we have a president who has a heart attack, who's a 3-pack-a-day smoker.
Yeah.
And a debate springs up as to how did it happen?
What a mystery.
Right. It's such a huge mystery. Is it the saturated fat or the sugar?
Yeah.
And I mean, it's fascinating because exactly to your point, and why I bring it back to the food environment today, the food is minimized. It is minimized relative to the solutions that can be offered up to deal with it. Lifestyle changes are hard. And I mean, we should probably chat about GLP-1. Now all of a sudden, hey, we do have a medical solution.
Well, do you know, I'm so confused about GLP-1s. So I started off as really against, but I have to concede that I am using them because for some people, when you're weighing up the pros and the cons of their condition, they may have a place, because I have patients who I cannot find any other way to help them. And the GLP-1s, one thing I'd say is that the food noise, they help with food noise. And of course, the other thing that's also really interesting is we know partly from Isabella Cooper's work, she's published on this, and there are other studies as well that show that low carb increases the natural production of GLP-1. Did you know that?
I think I saw
There's
that
good
one.
studies on it. Now, Isabella Cooper's one of the best, but there are good studies that say, so we need to rewind a bit. So GLP-1 is a hormone that you and I produce naturally in response to a meal. And the idea is that it reduces our appetite. So you feel full because you just ate loads of protein or whatever. The GLP-1 drugs, you know about the Gila monster?
Gila monster?
Yeah. You don't know about the Gila monster?
Mm-mm.
Great. So you know I love animals and I really like reptiles. The Gila monster is the only venomous lizard in the world. Its bite is very, very painful and the pain lasts for ages. And in the venom is a long-acting GLP-1. And what they did, they found this and then they manufactured it, and that is the basis of all the GLP-1 drugs now produced.
Comes from this Gila monster?
Yes.
Huh.
It's a replica. It's not the same as the naturally produced, because the naturally produced has a short half-life, maybe 20 minutes. So the drugs are not the same as the GLP-1 hormones that you produce. So that's why the injection could be once a week. But it's also why the side effects are very serious and long-lasting, because it's not the same as the GLP-1 that you produce. So obviously I'd have people produce their own GLP-1 by going low carb, which doubles the amount. But I have patients who it doesn't suit everybody. So I do sometimes use GLP-1s, but they're powerful drugs, and so in the UK we've had 82 deaths so far from people. This is published in the British Medical Journal. 82 deaths, things like pancreatitis, killing people from the jabs. It often doesn't kill people. That's a rare side effect. But they need using with care and they need supervision. But at the moment, it's like the Wild West. People are just buying them online. It's unregulated, I think. But I am fascinated. I'm so confused by where do I use them? I do love the paper that Tro Kalajan and I published, which showed that you can get low carb can give the same weight loss as SGLT2 inhibitor, as GLP-1.
Yeah, didn't you have both arms? Am I remembering this correctly? With the paper that you guys published, It was, you showed the comparison, but did you have an arm that was on GLP-1?
Well, what we had was we were comparing the best results of pharma because they published.
Gotcha.
So they've published at a year what will something like semaglutide achieve in terms of percentage body weight, about 15%, but Tro in the US was achieving 16%. So you can achieve results that are as good, which is nice to show. But still, at the end of the day, as a prescribing doctor, I am using GLP-1s for some people, particularly those who are addicted, so that low carb is very difficult for them to do.
Yeah, I've discussed this on the podcast myself. I basically have the same opinion you do.
Yeah.
There's some challenge cases in my friends and family who are adopting it, and they're just the biggest challenge cases. The bottom line is that for them, this just seems to be the one way that it's working.
Well, I think the whole thing, it all depends, doesn't it? Is it giving them an opportunity to learn to live differently?
The jumpstart.
Yeah.
Right.
Is it that? So that the fridge just looks different and that's how it is? What we don't know is what happens long term, particularly when we're thinking of young people. So I'm really don't know what to do about, say somebody's 25 years old. Well, that's a long time. Because we know when they come off it, they'll regain the weight. So am I doing a good thing? I don't actually know, because we don't know. We've been using GLP-1s in diabetes for years, 10 to 15 years, but the dosages were much smaller. And so I don't actually know what happens to young people long term. But then again, I do know that if you are really overweight, that can kill you too. So to do nothing isn't great.
And it's in the challenge cases I'm talking about, that's the situation.
Yeah.
The situation is there's all kinds of things that I would imagine that if they were willing to do, would be better than the alternative to where they were.
Yes.
So even if you, in general, and I don't want to sound as though I'm anti-pharma, because I'm not. I think we can be very thankful for a lot of the drugs that have come from pharma that have saved lives and so forth. But I will caveat that it is a common cycle that the trials do have things like run-in periods. They do have things like a lot of statistical considerations that often highlight the benefits and diminish the side effects. Where I'm going with this is, it's a two-edged sword with regard to the benefits can be realized right away, and oftentimes you can observe them right away.
Yes.
Things like long-term harms there may even be a lot more to the short-term harms that weren't showing up in the trials in the same way because of run-in periods that we do see out in the wild. But it's the long-term human component that usually you don't get until, and metformin is a good example of that, right? It wasn't until a lot of surveillance data was coming back that it started level setting that it may not be as great as it was originally thought to be. And that may be the case with GLP-1. It's hard, though, for me to imagine for these challenge cases who are considering this, that there's anything else I could have come up with.
Because they've probably tried everything.
They have.
And they're in danger.
And I say the same thing that I'm sure you're saying to your patients, which is, why not use this opportunity to see if you can find a way towards a sustained solution in case this really isn't it. And
what I add in for people is, okay, you've decided, they're just doing it anyway. So lots of my patients come to me and they've gone online and bought it. So I now have to deal with that situation because I can't stop it. So I'm saying, right, well, you're going to eat a lot less because that's how it works. You're going to be so much less hungry. You eat a lot less. So you have to make those calories count. So now, if you're to preserve muscle mass, nutrient density is what you and I need to talk about, because if you eat, your diet previously was probably nutrient poor. So if you eat less of that diet, it's even worse. So now calories must count and it must be protein.
Right.
And we're thinking protein and vitamins and nutrient density. And I think that's really important to keep GLP-1s safe and try and prevent people from coming to harm through muscle mass loss.
You're probably familiar with Ted Naiman.
Oh yes.
He's presented on a lot of studies.
He was at that same conference.
That same 2017 conference, right? But he kind of moved a bit, not necessarily anti-low carb, but more towards protein. The P:E diet and so forth, which is protein versus energy. I do believe, and have believed even before he was kind of getting into this, that we have a degree of hunger that is protein chasing. And there are a lot of studies that do seem to support that. Not indefinitely, but to a level of adequacy. And so I have the same concern you do, that we're kind of entering into an experiment where if somebody likes their cakes and their donuts and their ice cream, which are all high in fat and sugar but low on protein, that can create this exact issue. Because it's not even just muscle loss. We're protein factories. We need proteins for the hormones we're generating, for the structure of our bodies, right? And that exactly the same thing you're describing is exactly what I would be concerned about, because in order to preserve that capability, you've got to proportionately come in with a bit more protein. So, my hope is that to the degree with which this is helping a lot of people, they'll see it as an opportunity to make these changes.
It worries me because it's a giant experiment. To me, it feels like we've just said, oh, whatever, you can all go out there and buy it online. And I know so in the UK, 1.6 million people so far have gone online to buy GLP-1 hormone. Patients of mine who previously said they didn't have enough money for a continuous glucose monitor will spend 4 times more. That apparently they do have the money, and they're so desperate to try this that they're buying it.
Wow.
And then what's really worrying is then they find it works, so then they try and get cheaper supplies, and then of course sometimes it's not. It's completely fraudulent and sometimes dangerous because they're buying it. It's the Wild West. They're going online.
I've heard about this, where they're what's it called, compositing it. There's a name for it, where they're synthesizing these GLP-1 in various labs.
Well, sometimes they don't even bother to put that in the ampule because people will buy it. So there've been disasters where they put something else in the ampule because it's not always well regulated. And it'll be interesting in 5 years' time as to where we are, because I think it will change.
Before I forget, I haven't even gotten to these yet. This is what happens when we have such interesting conversations. This is from the desk. Once again, knownyourlabs.com/desk is where you go to submit your questions. This one is, when did a patient most surprise and delight you? What about the situation was the most unexpected?
What's happening? Something like that happens in every clinic I do. So I couldn't choose which one, but we'll find.
What's top of mind?
Top of mind. Got so many. A young man, age 25, came to me, and he was so heavy that I didn't have the machinery to weigh him. So there was no way of knowing what he actually weighed. And he also had poorly controlled diabetes. But he was on his way to South America for a holiday. And he said he came to get his lab results, right? And they were terrible. And what for me was really scary was he was literally going to South America the next day with poorly controlled diabetes and couldn't come back for 2 months.
Wow.
So what am I going to do? Because he's young, and how am I going to keep him safe? And he's so heavy I can't weigh him. So I actually gave him a continuous glucose monitor. I put it on his arm and gave him the diet sheet and said, this basically, you've got to avoid stuff that spikes. because there wasn't time to start the drug and know whether it worked. So that, I wasn't happy with that. Anyway, this young man came back. I didn't see him, I think, for about 3 months. Transformed. The before and after photos are amazing.
Wow.
And the point was, when he came back, we could weigh him. So I knew he was somewhere north of 150 kilos. And I knew his waist was more than 1.5 meters. So that's difficult. You'll have to convert that. But so his waist was way more than a meter, way more than a yard. What do you do in America for length? Are you yards? Are you feet?
Oh, yeah. No, I mean, we go by inches for...
Inches? Oh, you don't do feet?
Well, no, we do have feet. We just don't normally measure waist in feet. We're measuring
well, you'd
in
have
inches.
to for this boy. So he right. So he was 1.5 meters. So that's the same as, I think that's about the same as 5 foot round. Right? So 5'12".
Jeez. Wow.
Right?
Yeah.
That's right. But he comes back and I can weigh him. And he must have lost 20 to 30 kilos. Because he was down that many.
That's great.
But his diabetes was in remission. He's got a normal blood sugar. And this boy, a few weeks ago, sent me a photo and he's just run a half marathon. So he's gone all the way, had sleep apnea, high blood pressure, diabetes. His waist is about 5 foot round. Transformed to a handsome guy, controlling his diabetes with a CGM, don't eat stuff that spikes. Clever boy. And he's like a miracle. And it's made me so happy because it was very light touch. Because not then, he did another thing. He came back and said, I just want to show you, because this is brilliant. Anyway, I'm off to Asia now. And he went off, as young people do, he went off somewhere in Asia for another 2 to 3 months. And I thought, oh God, what's going to happen to him in Asia? What about all the rice? What will happen? Came back still fine. An intelligent guy. He just needed the leaflet, hope, and the understanding of the physiology.
Though, CGM.
It's feedback.
Exactly.
Feedback. It's powerful.
Exactly.
It gives me, CGMs give me hope because it's like the cavalry coming over the hill for us all, because people can no longer ignore the glycemic consequences of their dietary choices because the spike's right there. The hemoglobin A1C is the average sugariness of your blood over 120 days. So you don't care about that. You can't remember what you ate. But CGMs are almost in real time. So it's quite magic because he knew really fast. He had some early experiments and he knew that potato or bread or whatever really caused a lot of problem. So he just ate other stuff, sorted him. So that's the last case, and it gave me hope because he did so much of it himself. It wasn't the Dr. Unwin effect at all. It gave me CGMs. Oh my goodness, they're powerful. This young person can do that and then realize he wasn't hungry and just act upon it. Just sort it out. And then he moved, so he's not registered with me. He keeps in contact, so that's why he sent me an email. So a year later, he's moved elsewhere now, but he's looking after himself. He knows how to do it. And here's a photo of me running half a marathon. That is the magic of medicine, that right there, where, me talking about what's the potential of this young man? What's the potential? What could his life be? Which future is he picking? And he's picking, at the moment, a future where he doesn't have spikes, but he runs a half marathon and he's proud. And he's not a patient. I haven't seen him. That's the case that comes to mind.
You mentioned the diet sheet that you sent.
Yeah. So there's lots more to say, and that this is about where can people find out practically what I do, if because none of it's a secret. It's not like I make money out of it. So none of it's copyrighted. None of it's the Dr. Unwin diet. All of our work, I think I've now got 30 peer-reviewed papers. So I've got loads of publication. Some of the best ones are BMJ Nutrition. And we've one paper that's the most popular paper BMJ Nutrition has ever published in terms of the number of times it's been read. So isn't that amazing that just an audit by a GP in the UK it's just an audit becomes the most popular paper BMJ Nutrition have ever published. The altmetric score is 3,500.
Wow.
The average altmetric score, you may know of a paper, is about 20 to 30.
Right.
The score of that paper is 3,500. Now in it, I wrote it with Professor Roy Taylor, and I've tried to help anybody that wished to replicate my work know how to do so. So in the method, it's really detailed as to how we did it. And then in the supplementary files, I've chucked everything I can think of, including the diet sheet and the psychological stuff. It's all in. So this is BMJ Nutrition. So you just Google BMJ Nutrition, Unwin and Taylor. That'll take you to that paper. But there's an easier way. So 16 clinicians in the UK set up a charity called the Public Health Collaboration. So this was 2016. We've just had our 10-year anniversary. So we were 16 clinicians who thought enough of poor quality public health advice. We've had enough of confusion and a little bit in moderation. We want to help people get good results. So we set up, you call it a not-for-profit, do you?
No, I think there's both. I think there's a non-profit and a not-for-profit.
Well, something like that. But anyway, we call it a charity. It's a registered charity. So none of us make any money from it. That's called a Public Health Collaboration. And in the resources there is my diet sheet, frequently asked questions, all of the sugar infographics that are now in 39 languages. So these are the charts where you can see that a banana is 6 teaspoons of sugar and a bowl of rice is 10 teaspoons of sugar. That's in, I think, 39 languages, and people are volunteering all over the world and translating them. So I keep getting new languages. So the diet sheet, frequently asked questions, loads of papers, and lots of useful information, and it's all for free. And it's none of it copyrighted, so you can steal it. And I will not pursue you through the courts because I just think, that if it's useful, I'm just pleased. I don't need to make money from that. So those are the many. And then the other thing, follow me on Twitter, because that every week I'm consenting patients as patient of the week. I've got one ready for tomorrow, which is somebody who for 6 years now, this is somebody with type 1 diabetes, and she forms a really useful, interesting N=1. And I think I shared one of these with you once, where the problem with N=1 is the scientists will say, well, you can't get a p-value. So where are the statistics? And you can, because I've got a medical statistician, Christine Dellon, who's worked for free for me now for 6 years. Everything she's done, she's worked for free to help me. And so she does all the statistics on the papers, and she's a professional medical statistician. Anyway, I've been puzzling with her about N=1 and how does it fit in with science? And we've come up with what we think is the answer, and that is that each person can be their own control if you have enough data points. So that this patient was 5 years normal care with many data points and 6 years low carb. So that actually gives a series of data that she is her own control. And so I've got the graph showing, and it shows the mean on normal control and the mean on low carb, and the difference between the two, and the p-value. And I'll I'm going to put that on over the next few days. But that's somebody with type 1 diabetes, and she's reduced the use of insulin. Of course, she has to have insulin to keep her alive, but she uses 50% of the insulin. Her health is better, her weight's better, and her glucose control is much better. So that's another great case, because I happened to see her last week. She comes to see me once a year just to say, I can't believe it's still as good as this, but also I don't understand why no doctor told me about this before.
Particularly type 1 diabetics.
Yeah.
David, it's you know how you mentioned 50 years from now, doctors will look back and say, I can't believe they thought this. I mean, for type 1 diabetics, that should be the first conversation, is low carb.
Yeah.
It should be the first one.
Well,
type 2 diabetes, I'm somebody who will say, I think that there are more routes for those who have type 2 diabetes than necessarily going specifically low carb. The catch, per what Ben Bickman would say, is it's going to be some version of low insulin.
Yes.
So you're still going to have to figure out how to keep your insulin levels low if you have type 2 diabetes, particularly if you're overweight. You're going to need to lose weight. But in the case of type 1 diabetes, I mean, I got to interview the GOAT, Dr. Bernstein, for the movie, which was a great honor.
It was fascinating to see him there. And of course, he led in this. Yeah. It's very important, though, just to say type 1s need insulin to keep them alive, but how much insulin they need depends, and there are consequences of too much. But I think Dr. Ian Lake stands on the shoulders of Dr. Bernstein, really, because he's now carrying that on. But there are others as well. Is he a dentist? Very fit-looking guy. Big guy. Nick? No, you'll have to edit that.
Oh, I think I know what you're talking about. Yes. I intend to have him on as well. Or I forget, I want to get at least one more of these. Also from the desk, for individuals trying to rebuild trust with a trustworthy doctor after a long history of feeling dismissed or blamed when standard dieting didn't work, what is a place to start when you're feeling jaded or guarded? So many seem to struggle with this, even if they want the partnership.
Yes, so I'm asked this a lot. How can you improve your relationship with your doctor,
right,
and work with him? So I think one of the things is to say, I'm interested in seeing if I can improve my health. So that's a shared goal there, No doctor's going to disagree with, I'm interested in sharing my health. Would you be comfortable? Would it be possible? I've got an idea, something I'd really like to try. If it doesn't work, I'll give it up. But I'd be very interested in just changing my diet a bit. And we've got my baseline labs. Could we do it again in a month and see how I'm doing? And you wouldn't necessarily say you're going low carb or whatever. You're just saying, I'm going to try hard. And most reasonable doctors would support a patient who says, I'm interested in improving my health. And I think I should I need to take more ownership of my health. I just need the feedback to know how I'm doing. You don't necessarily need to be that specific what you're doing, unless, of course, you're on insulin. And that'd be one way of just saying, I'd like to just experiment. Or you could say, I'm going to reduce my carbs a bit and see how that goes. But let's do a blood test. Would that be okay? Can I have a blood test in a month and see how it's doing? The other thing, of course, is to consider buying a CGM, because then you can share the data with your doctor. So it depends which system you use, but they're affordable. You can buy them on Amazon. So it's possible to say to your doctor, my plan is I'm going to buy a CGM, I'm going to learn from it, and then I'd like to share with you what I've learned in a month or 2 weeks. Would that be okay? Because I'm excited by the possibility of doing better. It would be a very grumpy doctor who didn't engage with that. And I think the key thing is the flexibility. If I make an error, I'll obviously stop it, because that's true, isn't it? But that's like a wedge for the patient. There are other, it depends. Patients have done it many ways. I mean, but that's working with them is better. Sometimes people are a bit adversarial, and then they start bringing in published papers and so on, which is, it's a bit challenging, really. I don't think your doctor's going to like that very much. That, so your Dr. Google and my qualifications don't matter at all. Try and keep your doctor on board, because he does have expertise. But you also have expertise in yourself, is what I'd say. And each of us understands ourselves better than our doctor, probably.
I'll say what I say often on this podcast, which is no one can take more ownership of your health than you can.
Yeah, I agree.
And the placing your doctor in a position of a god is not fair to you or to them. So it's at the end of the day, you may need to be the one who emphasizes that you're expecting a partnership.
Yes, because that's so good, because of course so many doctors just are like I was, which you may have had years and years of not experiencing partnership for whatever reason. So signaling, I am interested in I feel I should take some responsibility.
Right.
That's a good opener.
It is. And it's, and just that I like this term as kind of an opener, which is, I want to understand.
Yeah.
I don't want you to just give me stuff. You probably have many great patients that you work with, and that's where your dynamic is with them. But for me, I want to understand why you're telling me to do the things that you're telling me. Please, lay it out for me. I will take the time to research whatever I need to on what you're telling me. Where does your opinion originate from? Beyond your patients. Another question I just have for people in general of any expertise is I ask them, what's an opinion you've had for a long time that you've recently changed your mind on? And I think a lot of very thoughtful people will have things that come to mind pretty quickly when they take a moment.
Yeah, I've got a smorgasbord.
Exactly.
Family life. God, yeah.
And a lot of times those things are the original opinion was more rock solid, and the new opinion isn't a replacement and a new rock solid version. It's usually some way in which you go, I'm not even sure of what I believed before. I'm more unsettled and a little less certain. So a lot of us, I think, it's that Dunning-Kruger thing, right? Where we had a greater level of uncertainty early in, and we've learned to be less certain appropriately.
Yeah, I become anxious by people who say it is or it will be. I like the word probably, or very often I find I've become more nuanced, because I was wrong once before, so it's possible I could be wrong again. So I think we should hold our beliefs reasonably lightly and be prepared to adapt. And the iteration thing that you said, because it's like I said about the science of medicine right at the beginning of this talk. It can't be that I know everything. That's plainly ridiculous. And it can't be that in 50 years everything I now know or think I know will be proved right. Some of what I think will be good, and some will go by the by. And so it's arrogance to believe that evolution's finished, or the iterations are finished, because even in the last 10 years I do things differently now than I did at the beginning, very differently. Particularly the psychology of it, particularly the maintenance, particularly continuous glucose monitors. I would say, challenge you gently. So when I'm looking at my population, you said that there were many different ways for drug-free remission, potentially, which is true.
Oh, yeah.
Yeah, it's true. What I would say is, if you were in my position, what you got to do is, it's like betting, isn't it? In the 10-minute appointments, for those patients I've got to try and think, what's the easiest way to help them?
Yes.
And I would say my experience is that avoiding the foods that put up your blood sugar, for most of my patients, is the easiest route. Partly because, so you could say like exercise would work, but the average patient that I've got with type 2 diabetes, the average is about 60 years old, and they're heavy. So the idea of exercise for that group of people is quite problematic. You know, my average patient is quite heavy and they're 60. Now, they do come to exercise later. If they can lose weight first, exercise becomes safer. In my early days, I tried to get them to exercise, and some of them damaged themselves because they were so unfit and heavy, and they started running, which is maybe something they didn't taper it and they were too heavy. So my experience is that on the whole, diet is the easiest way to do it. And where I live and work in the north of England, a low carbohydrate diet is the easiest one to get over. There are other diets, but you have to work out, what are your population going to understand? What can they access? What can they afford? And so it's for people all over the world to work out the best way to do it. So I don't disagree that there are other ways to do it. But for me, with my population, that's my best shot so far. And it delivers, which I don't think anybody else has replicated in the world. It's delivering. So if we look at all the people with diabetes in the practice, over 50% of them are low carb now. That's what I've achieved. Of the ones that are low carb, 50% or 25% of everybody with diabetes has achieved drug-free remission. So I've got 157 cases of drug-free remission. So what you have is an NHS population allocated to me by the government, of which half find low carb acceptable. And of that half, another half have got drug-free remission. So that is unusual, very unusual to get. So I've got a quarter of everybody with type 2 diabetes into remission in my practice.
That's amazing.
It is, and I'm not aware. It's very interesting worldwide. I've got people chasing me and go on, beat me. I want people to do better.
Right. No,
because it'd be good. That's what I would say to anybody is, if you've got a better way of doing it than me, please do it, because there's so many sick people needing help. If you find in your area a different diet works, well, audit it, show, publish, and spread the word.
I think I want to qualify something though. The pushback, you basically just replicated exactly what I would say, which is that in my experience with my own family and friends, nothing comes even close to the sustainability of low carb relative to those other options.
Yeah.
So for example, I have, I won't identify them, but I'll just say that there's a couple of family members on the extended family side who said, I can't do low carb. I need to do Weight Watchers.
Fine.
Weight Watchers was working for them for, I want to say, a year and a half or something like that. They ultimately found their way to low carb anyway. But for that year and a half, it's working for them. I do have a friend who is arguably on a high carb diet, even though they're diabetic, but it's ultra fibrous, no refined carbs. So they just really like plants.
Oh, here's another, that reminds me of something. So a dietitian came to do her PhD at my practice, and that was great because she actually measured what my patients eat, because I was missing that part. All I've got is the result of the diet, you see.
Right, but not actually the...
Yeah.
Right.
So suddenly I've got what they eat. And so it's true that they are low carb, and the average carbs they have in my practice is 70 grams. And low carb is under 130, great. But there are some fascinating outliers. So one of my cases of drug-free remission was actually consuming 200 grams of carbs a day. But relatively, it was vastly less than they were eating before.
Right.
Because they started off at 350. So that you see, that explains some of this, because it's all about where did you go on the spectrum of sugariness. And you may not be low carb. He's at 200 and it worked for him, but he'd moved relatively. So I thought that was such an interesting case. So not all mine are actually low carb. There's one of mine who you would say on paper is high carb, but actually you haven't looked at what he was at baseline.
Right. You've got it. If you don't measure it, you can't manage it.
Yeah.
Right.
Yeah.
Let me hit you with one more thing,
yes,
which is AI. Has that impacted how you practice medicine? For that matter, has it impacted how your patients approach their care?
That's a really interesting one. I mean, AI is impacting all of us. And I've been thinking about this. Did you ever read the book Sapiens?
Yes.
Right. In it is a fascinating quote. And it's to do with every single time we have a significant step forward in technology, we lose freedoms. And so I've thought about that a lot. And I think it may be true when I see the addiction to phones. So I have 5-year-olds scream and cry when the tablet's taken off them for me to look in their ears. They're furious. I have whole families totally silent at dinner where they're all on the tablets. I see them going out for dinner. So technology brings with it advances that I celebrate, and it's how I've done so well because low carb is essentially a sort of social media, a grassroots revolution. And you and I would never have met, and we wouldn't have done all we've done without social media.
No, my research,
would be impossible.
Entirely reliant on social media.
But here we have a really significant step forward in technology, and it represents a threat as well as an opportunity, because it's giving control to who? And so yes, I am using it. I'm experimenting with it at the moment, and I find ChatGPT lies and invents references that don't even exist, and says it can do things that it can't. So, and yet equally, it can save me loads of time. If I want to write something, you can just do it. Funnily enough, I use ChatGPT to find the very reference from Sapiens on that. So I asked ChatGPT, that book Sapiens, didn't say something about, the loss of freedom that comes with every advance in technology, and it found it. So,
well, and if I recall correctly, one of the most fascinating things it was bringing up was how we were domesticated by agriculture. We think we domesticated agriculture. Yeah. Actually, agriculture domesticated us, was its point. Until then, we were foraging and we were moving and hunting, and we kept on the move, and then we found a way to stay in one place. Yeah. And that was a huge change.
Yeah. Sapiens is a fascinating book.
It's a great book.
Just come back to the AI. Yeah. So, I mean, another thing I did recently is I said to ChatGPT, what are the dangers of meat eating? And it says, cancer and blah, and diabetes and everything. And then I said, well, what do you think about epidemiology and its place in science? And of course it says, well, epidemiology suggests associations that need checking. So I said, that's what I think too. Will you now please look at meat again and eliminate all nutritional epidemiology? And let's talk about meat again. And then it said, that's made a big difference, because actually, if you're just thinking about non-processed red meat, there's surprisingly little evidence against it. So you see, the thing with AI, it depends on the questions you ask and the framing you give it. Because the AI gave me two answers. Meat was very dangerous and needs reducing. And then when I did it again, remove nutritional epidemiology, which it agreed could only suggest association. The answer was completely different. So there's a danger of AI before you've even begun to look at the power base. And I'd illustrate that with another thing called open evidence. You have that in the States. It's an AI thing, which is great for academics to look for references. And it was Adrian Sotomato who suggested it for me. And it was great because it saved me loads of time. Please, can you give me a reference on this? But I noticed it never used the British Medical Journal. I thought, well, that's weird. So then I'd say, can you suggest a paper written by people I knew who had published in the British Medical Journal? And it wouldn't be able to find them. And then I'd have to go, right, here's a specific paper now. Here are the authors, and this is what the paper's called. And then it goes, oh yes, this paper, And it was affecting the references it gave me, and it was avoiding various journals, and it was very, it really promoted the United States and the research you have above what Europe does. So there's a power base being used. So the potential for AI to be misused could be very great, couldn't it? Because people just trust that instead of their own mind. It's a bit like as cars become more and more automatic, we forget how to use gears. And then you can't even switch the lights on because you don't know how to do the lights. Or, the TV remote. It's like an exam for me, the TV remote. So AI, I'm using it, I'm fascinated. It's very powerful and it has pros and cons. And we, like everything, we need to weigh up the pros and cons with a view always to that skepticism that it's probably going to be used to enslave us eventually.
So 3 points there. That I was going to be 2, but then you mentioned the last one, which I should mention. Point number 1, and this is something everyone should know, there are top-down directives for AI as to why it often will give an answer that seems to be part of conventional positions.
Yes.
Right. And what that is that the company that hosts the AI is itself vulnerable.
Yes.
If there's screenshots of, hey, I just asked it about, fill in the blank controversial topic, and it gave me this controversial answer of its own design.
Mm-hmm.
Almost always, invariably, its initial answers are going to be top-down informed, but additionally directed to fit a lot of mainstream narratives.
And just to support that, they do a weird thing, which is they include guidelines as evidence.
Right.
Which they're not, because they're not always referenced.
Correct.
So the other thing I had to do to ChatGPT was I asked it, and it said I'm using guidelines. And I said, well, are those strictly evidence-based? And it said no. So I said, now, as well as nutritional epidemiology, will you please also exclude guidelines because they don't fit my criteria? So I agree. But the point, they're even using guidelines like without realizing that, because it's safer. So I take that point.
But they do realize it.
Yeah.
Or let me put it this way. The company realizes. The
Yeah.
company that hosts the model recognizes that they get in huge trouble. You'll notice there's no big model that's hosted where they tout that they leave it entirely open-ended, open-minded to process as it sees fit. Because the risk is that it gets sued, or the risk is that the US government or the British government or whatever government is that it's in the territory of is problematic. The enslaving thing is an interesting one.
You went straight to 3, but there's got to be 2 in the middle.
There is 2 in the middle, but there's a reason I want to
go to the enslavement.
I want to go to the enslavement thing. Now, while that might be a dramatic term, it's not as dramatic as it might sound, because exactly what you're saying with regard to how much do we then find ourselves reliant on new technologies? I would argue of all of the things in our lifespans for which there was a technological leap, nothing comes anywhere close to this. I've never seen anything so widely adopted so quickly at so many levels by so many people. Ever. Nothing. Like my mom, my dad, they're using it. All of my siblings, all
how
of my
do you
cousins,
get around? How do you find your way to London? How do you get? They're asking it all the time,
and they're at various thresholds. So my company uses it. Own Your Labs. My company uses it, of course, because I have developers. The developers use it to enhance their productivity, which is way higher now than what it was when we were a smaller team that did not have access to AI. Our prompts are extremely extensive and complex. My mom has, 5-word prompts. But she loves it to death because of the degree and threshold of information it gets. I have another friend who concedes, this was only just recently, who concedes that he literally vocalized it this way. He's addicted to its affirmations. He has, because of the nature of his life, there's a lot of difficult personalities in his life. And so he just concedes this up front. He knows it's not a human, but he just likes interacting with it for mundane tasks only because of how much he appreciates the affirmation coming back. And I naturally was saying, there's all kinds of things online that you could read. It's not that it really knows you as an individual in the way that you think it does. And
see, I think that last thing is the most chilling thing.
It is.
My blood runs a little bit cold there, because again, they're going for our hardwiring.
Right.
They're understanding our hardwiring. And what I think is there's a battle for our consciousness. That I see it that big. I believe there is a battle for our actual consciousness. Go down any street and watch the people, going on any train, anywhere. When I was young, what did people do? Because they didn't use mobile phones, and they talked to each other. Children played games. Children told stories. Life was very different. And now there's silence because they're all staring at their phones. And I think this is, for me, the battle is for our very consciousness, and it's diminishing something vitally human about communication, potentially. But then again, old guys always say things like that, don't they? So I'm probably just an old guy fussing. But that for me it really worries me for young people, because yes, you can use it in a very intelligent way, but then you can start, maybe that's instead of having a friend, somebody to talk to instead of your mum. We're waking up to mobile phones now, aren't we, internationally, as highly addictive and a worry for children. And this is another bigger leap without any pros and cons thought. So just because we can do a thing doesn't always mean, I think we're beginning to think with children and social media and game playing that some of them have come to harm.
Well, here's what I can imagine is a surprisingly shocking kind of doomsday scenario test would be, imagine shutting off the power for 3 days. Anywhere.
Yeah.
Anywhere in a Western world right now. Like, imagine it happened in the UK. Imagine there was just a power outage, or, worse, like, not to get into a whole other realm of discussion, but let's say that there really was something like an EMP, solar flare or something that just knocked out all kinds of, how would the populace at large, like, this was already stuff that would be pontificated, 20 years ago. How much would you be able to interact with the world as you know it today without power, even for a brief period of time? How would the populace at large interact with each other?
That's a fascinating question.
It is, because
the shops would all run out of food, and even if we had it, we can't buy it, because that would all stop, and you can't get there either because a lot of the cars would stop working and the trains wouldn't work. So you'd have pretty well riots, likely, and food would be an immediate problem. And it doesn't. Yes, I agree. 3 days would be chaos.
But you go back 20 years ago, if there was a blackout.
Yeah, we had them.
Right. Exactly.
We had them. And you lit candles, and it was an adventure that I remember. So we had that. Yeah.
We're on holiday right now as we're filming this, and Sharon's phone, I'm not sure exactly why, but it doesn't have the compass component to where it actually points which direction it is, right? On her phone. On my phone, it does have that feature, so it's a little bit easier to follow. So there's been a few times where I've been like using her phone, or trying to navigate to a particular spot. Never mind the fact that we're at such a technological level where I'm already expected that I could get to the, I can put in an address and that'll show me exactly where I need to go. And this internet connection is taking too long. It's not really taking that long. If I were to go back to 2007 and compare what, data speeds were then compared to what I have now, this gets back to why AI, it's expectation level. This is the good and the bad of us as humans, which kind of gets back to where my second point was that was coming out before. Our greatest strength and our greatest weakness is our adaptability. We adapt really quickly. The new normal shifts. And for when things are getting better, that's not always great, because we just, as fast as it became available, we now consider it a need. And we're now reliant on it.
Yeah, that's a
good
point.
And now we're upset when you're taking it away, when just like a few years ago, we didn't even have it. It also makes it to where we keep looking at the Joneses. Well, these guys have an even better version than what I have, not even realizing that we live far beyond our parents and grandparents and so forth, and the kinds of hardships that they had to deal with, right? The other advantage, though, is if things do go sideways, we often find ways to adapt to that new normal. It's just that the transition between is very relevant. And so the power outage, the reason I bring that up is, if you have the blackout before, that shift between what you had gotten used to where you need to get used to now doesn't feel that far relative to how it is now. Now, I mean, we live on our phones, and I can certainly say I live on my phone. I'm very aware of what's going on the internet much more than I should. It's not that healthy. I don't think it's that healthy for my friend to have that kind of affirmation. He's getting a human wired connectivity. I saw this recent statistic where I think it was survey based, so I take it with a grain of salt. But it was a survey of a number of people who had AI girlfriends and boyfriends compared to the number who were actually on dating sites. And I think I even retweeted this one, because what was so fascinating about it was that a lot of my single friends will say dating is worse than it's ever been, because the rules of dating are all over the place, and the nature of how these apps work makes it even more confusing because you can't really self-sort in the same way. You know how many people are out there that are like at your level. It's not like a school dance kind of thing where you know this number of people are left over where I could be a good match at. All of that stuff, our digital lives have thrown up in the air, right? So bringing it back to AI, yes, it's not even just that I've watched it happening. It's that I'm really blown away by how fast, how lightning speed this has been. And that's where I want to bring it back to medicine. If it's not affecting your practice now, I mean, I've definitely talked to doctors they're coming in with printouts of what they got from ChatGPT, or they're reading it off their phone. They've gone ahead and looked, and there's pros and cons. If they can do some of the forward research, that actually will be helpful to a doctor.
Yeah, well,
that's potentially good.
This is like the Dr. Google thing.
Yeah.
It's only an extension of that. I started off by being annoyed, but now I'm actually pleased because this is a person who's interested, so I can work with their curiosity to say, well, hey, well done, that's really interesting, but have you looked up this and look at that? And oh, I've written a paper here. And let's talk about physiology. So I like working with curious people. And if they've looked stuff up, I now think this is somebody who's open, they're trying to help themselves. Well done. So I'm quite happy for people to do that. What mustn't be forgotten is that experience is very useful, because what's very difficult is over 40 years, I've seen so many cases and I've so much experience of thousands of patients and what happens, and I recognize patterns quickly. And I think that has value too, as to what might be relevant to the person in front of me, because AI can't know much about them. Maybe it will eventually.
Yeah, I was going to say, I would offer a counter.
Yeah.
That, and this is why talking about these top-down directives and the swaying of the objectivity is relevant to making it subjective. I do believe AI, if we let it, can bring us a level of objectivity we can't provide as humans. And that's the most exciting thing to me. As an engineer, we have a way.
Yeah.
We could, if we let it, we could create,
if we let it,
a diagnostician.
Yes.
That's far beyond anything any doctor today could do. Right.
Yeah, I agree. And to support you, this is why I started working with insurance companies, because they have the data and they know stuff about lipid profiles, and they know stuff about who dies and where they were and why they died and all that. And that is very powerful. So the insurance companies, but this is even bigger if they'll let it.
If they let it.
And the track record of capitalism isn't great when it comes to uncomfortable truths that affect consumers and consumerism. So that's my if. So it's a bit like the World Wide Web started off as a sort of it's a friendly kind of a thing. And now it's become a consumer type of a thing. And now it's become what young people are addicted to kind of a thing, and a way to make money. And you know, I keep wondering, am I seeing the symptoms of the end stage of capitalism? And is this because it's all towards consuming and selling and consuming more, but that could be again very old guy speak.
It might be, because my counter will be I'm actually pro free market of ideas and free market of exchange. The catch is that almost all versions of what's described as capitalism is typically corporatism. So when you get big companies and big government and they get friendly with each other, usually the real mechanisms of capitalism start to fall away. Because
perhaps we're talking about the same thing, because that's what I've observed, where increasingly what governments can do about diabetes.
Right.
Or they don't really have their hands on the levers of power anymore. That what Google can do or Amazon is far greater in terms of the influence.
As was diabetes.co.uk.
Yeah,
right.
yeah.
So I'm not worried as much about a free market of ideas where there's some bad ideas out there as I am some entity we've given the enormous power of controlling what we can see, what we can say. That I'm a lot more worried about, right? And so to the extent to where, your concern on these being the end stages of capitalism, consumerism in and of itself is not a problem. That's how we got to where we are, right? Where the algorithms are good in a way that is scary is the scary part. Outrage sells.
Yeah.
But that's not a new problem. That's an old problem. Go back to the papers. If it bleeds, it leads, right? A key consideration is the culture itself, is the people. The people have changed to where there is a level of, take the news, for example, take media. At the time that we were growing up and that we were seeing, cable news come around, I think that there was a lot of effort toward this sense of aiming towards objectivity in the delivery of news, right? I feel like that sense is kind of out the door. And I'm not trying to pick on one particular political party or not. I'm just saying, relatively speaking.
And I think, as in all these things, you're ahead of us in the States in that. And there's such a big difference. Just again, to give you an example, I have been able to publish stuff in the press in the UK, loads. So I will have had 70 or 80 things published in the main papers here. 70 or 80. I had one a few weeks ago, 1,600 words in the Telegraph.
Wow.
That can't be done in the States. All my friends in the States say, how are you doing it? Because you've lost. Your media are no longer interested. They're not accessible and it's closed down. And we still have in Europe something left where I can be published and my story's done. I've done the BBC, I've done television, radio, and all of the largest papers of all. There isn't any paper I haven't published in. And that's still possible here. But if we follow the States, it's no longer possible. Something is different over there. I've not understood it. It's like you don't have any free press anymore, or anybody, somehow they can't get published. Or the news story of like my cases of remission with before and after photos just wouldn't run apparently in the States, or the papers won't take it up.
I think that there's more. I don't know how much this is the States versus the UK, but I think in the States, a lot of the major papers tend to have this is something I don't love, but I keep seeing in real time, which is if you lean a little bit more in the direction of like pro-environment, you lean a little more towards plant-predominant diets. Mm-hmm. You will then naturally lean against a low-carb diet, since they tend often to be meat-centric, tend to be higher in saturated fat.
I couldn't believe it that diet is political.
It shouldn't be. It
shouldn't be. I know it shouldn't, but I've been told again, and so diet in Europe is not a political thing. It really just isn't.
It's very political in the States, yeah.
Apparently my diet defines my politics. I can't believe it, that a taxi driver will assume from what I'm eating that he knows about all the rest of me, including how I would vote in America.
So I think a part of that though is also just because we have a two-party system.
Yes.
If you're landing in this tent, you must have all the other parts of the tent. Mm-hmm. Whereas here in the UK and so many other, basically almost every other place in the EU, it's parliamentary, multiple parties, consolidating forces. There may be like some, stalwart ones like the Tories that might have been around for a long time, but no, it's hard to determine where somebody stands or what party they're in based on a few things they've said or some position that they've had, because a lot of your parties consolidate lots of different positions.
Yeah,
right.
I see it. So just to go back to the AI. So don't you think it's a bit like we're allowing something to rampage through society without any idea of where it's going or what regulation might be needed to keep it safe? Like mobile phones all over again.
Yeah, but again,
I'm using it. But...
So then who do you give the power to determine what is and isn't safe? If it's an emergent technology, here's what me, a technologist, would say. We've been here time and time again with every generation. Every new technological front came with it a whole bunch of people imagining how it could go wrong. Now, I'll caveat something. I, as a technologist, even though I just now said that, concede the fact that so many of us do feel this time is different. But we have this other problem, which is we're not the only ones making AI. We're not the only technological frontier. China is definitely well into the game. And that's a relevant component to consider, because if this is another arms race, and it surely looks that way, what are those limits? What are we imposing, and under what conditions? Right? So set aside things like warfare, etc., and bring it back to medicine. If AI, if we got it advanced enough to where like next week it cures cancer, but we're worried. We're worried it's going to go too fast and develop the next proton bombs, right? Then how can we weigh both of these things that are in the unknown? You see what I'm saying?
I do. I'm still just thinking around it and through it. So what, against all that, I find something my son said. He's 25. And he said, "Dad, I wish I lived in the 1970s, because in the 1970s, you didn't need a diet expert, an exercise expert, a sleep expert. You just lived, and you were free to live. And now it's taking more and more intelligence to survive. It's harder and harder to avoid all the dopamine trips and the addictions, harder and harder. It's harder to negotiate through life, and everything. You can never get a human being to discuss the gas problem or the water problem, because they always put you off and say that you need to deal with the machines." And I really, what I notice in society is it's essentially becoming very unfair, because the poorer people in society are dropping lower and lower. The people that, don't have access to all of this, and there are people, and they're dropping lower, and their diet is worse, and their experience of life is worse. And fewer people are clever enough to negotiate what needs negotiating to be a success in the modern world. And I think I really regret that. So the experience of being human is becoming harder for more people. That's what I see. And in England, you've got a wonderful, as you go further north, people are poorer and they're fatter. Their life expectancy is dropping as part of all this, somehow as part of all this, compared to the simple life that I had as a child in the I was a child in the 1960s and early 70s, where diabetes was very rare, asthma was very rare, mental health problems were very rare, and we ran around as children and were free. So I think it is getting harder and harder. You have to be brighter and brighter to negotiate simple things like moving house, paying your taxes. It's getting really complicated. Jen and I often deal with, we think, God, how hard, I've been on for 3 hours trying to get through to the insurance company, and it's, I'm having a terrible day. But again, my perspective again is the old guy. And I remember my grandpa saying, I think I've had the best of the world, David. And I'll die thinking I probably had the best. My worry is maybe he did.
Right.
Maybe he did, because in his day, the experience of childhood. So I'm going to share something else with you. I have 4 very unusual grandchildren who have been brought up low carb. Their mother is our daughter. And these kids have been low carb all their lives, but they do not have screens. They're not allowed, they have no television, they don't have screens.
Wow.
And so recently we took them on a journey, and it took an hour and a half. Now, my memory of kids is being very annoying on long car journeys. But what happened was the 12-year-old started inventing a story. His story went on for an hour and a half, where he elaborated this story, and he asked his siblings what would they like in the story, and they wanted a witch, and they wanted a dog, and they wanted a dinosaur and a crocodile. And he invented the story and kept saying, are you bored? Do you want me to stop? No, no. All we heard in the back of the car is these 4 kids elaborating this story. They have the ability to use their imagination in a way that is quite unknown for other children I've ever met, because they're used to amusing themselves. They create music, they create art, they just make things in the garden. And again, their experience of being children is like mine was. And yet I didn't think those kids existed anymore. But how interesting they could exist. And they're very restricted. They would seem to have lost freedoms because they're not allowed a television. And they are, the older ones are allowed a mobile phone, but only for a very restricted time. But their creativity and their ability to concentrate 4 hours. Another one of them decided that she would learn to crochet, and she was going to design her sister a swimsuit and crochet it, which she did.
Oh, wow.
Age 9. And, you know, isn't that interesting? Think about the Brontes, who, you remember them, the Bronte sisters who wrote and painted, and, you know, in the beginning of the 19th century. And I think what's happening to our children, I come again to that, what's happening to our children is very, very sinister. What's happening to them physically, but what's happening to them psychologically. They are bored if they can't have a phone here. They can't bear to put the phone down while I examine them. Well, that's deeply, deeply worrying. It's so fundamentally worrying. So it's difficult to be cheerful when I see, again, whole families go out for a celebratory dinner, like, yay, and the silence. No chattering, no joking, none of all that should come with family life. And I see probably the AI just another step, probably in enslavement, because what I see of the people in the streets is they're losing freedoms that those children still have just. So that's what I think. But then again, I'm still quite a cheerful person. How's that? Dear me, how's that? Oh, because the nature stuff.
Yeah.
Because I love nature, and you know, it may well be that we'll all screw up, and when we do, nature will come back. Look at Chernobyl. Amazing what's there.
I think we'll be okay. It's every generation before ours, even for as different as this one is, it's been a pretty good record. We still managed to keep rolling it forward.
We are adaptable, but still, what's happening to children, it's not great.
I agree.
And so they're not adapting, are they? You see, they are not. They're becoming addicted. They're not adapting. So that the whole dopamine thing and addiction, there's a lot of addictions to deal with now for young people. They've got quite a selection. And to avoid all those addictions, how many of them are going to not get addicted?
Well, this is that key distinction, right, between something that's an isolated, say, substance abuse versus broad, right? So in the case of smoking from 60, 70 years ago, it's not even just how it was thought of then, it's also that it was in widespread use everywhere. So it's by the same token with these screens. It's one thing if it's just that you've got a few friends that aren't really good influences on you, but it's just those few, and everyone else is not highly addicted to their screens. But no, you're in a world where everyone is meeting on Facebook, they're meeting on Twitter, they're watching each other's TikToks, and why aren't you? Why are you in this? You don't have a TikTok account? How am I going to DM you? You know, it's definitely something that, again, is just happening so fast that it's hard to...
Well, we don't know where it's going. Certainly, I think it's going to eliminate a lot of jobs. That's, quite likely, because it's problematic employing people. So if you could not employ people, that would be good. My father was an inventor and an industrialist, so he had an electronics engineering company. And he said if I could ever engineer people out of this building, I would, because he found employing people so problematic.
There's sort of two schools of thought on this, which is we don't really truly lose jobs, like to the extent to where more people are truly unemployed until we have such a technological advancement that more people can just be cared for. So there's the...
Oh, I see. I mean, the care sector is going to go up and up.
Yeah. So one of my engineer friends actually put this pretty well, which is there's a point where AI and robotics are just all of our servants. It's that we're all living as kings, and we're just the needy meat bags, is how he described it, the needy meat bags. You just have to hope in that would-be future that artificial general intelligence, AGI, doesn't see this as a liability. It says, why am I supporting these needy meat bags? It's a problem for us.
It's very dystopian, isn't it? They could just turn on us or not bother with us anymore.
I mean, we've had a pretty long cycle as the apex predator, and now we're building the new one, right? So we're just going...
Well, I mean, the other thing is, there is no country in Europe, where the birth rate is replacing. We're all way lower, and where is the States in that? So you've got to, each woman has to produce about 2.1 children to sustain the population, and we're down to about 1.6. Poland's down to 1.3. And no country has reversed that trend ever so far. Once your population starts diminishing, and that's across Europe. So what's happening to the birth rate in the States? Do you know?
Well, it could be all these new AI girlfriends and boyfriends.
Could be, couldn't it?
Can't make children with them, right?
No. Well,
Did you hear about that famous mouse experiment where they made like a mouse utopia? It's
No.
I guess it was like in the 60s or 70s.
Yeah.
It was an experiment where they had a huge number, I think it was mice. It might have been rats, but mice, and they were all in one giant, it seemed like it was cylindrical, but it was gigantic. And what they did was they gave them abundance. So they had places where they could breed and ultimately make their own cubbyhole areas, but they had an abundance of food, abundance of water. And they bred out and populated a lot, and then eventually they started to die off, and the birth rate dropped.
Yeah.
And eventually it just didn't work out. I can't remember exactly how it concluded, but effectively giving them total abundance and caring for all of their needs was disastrous for them, right? And so it's
that's interesting. There's a place in the UK where they've kept cattle for 1,000 years, the same cattle. They're called Chillingham cattle. They're white, and it's very unusual because this plot of land has been owned by the same people, and they've kept the same cattle there for 1,000 years.
1,000 years?
Yeah, and
Wow.
they're pretty too. They're white with little black markings, and we went to see them. But they don't regulate the population at all. It regulates itself. And there's loads of bulls, but what's happened is the fertility rate has dropped and dropped and dropped. So that's another population where the fertility rate has just dropped. So that because otherwise you'd think, well, they'd all starve to death. Because they've no wolves or anything. And what's regulated it is the diminished fertility rate.
Wow.
I don't know much about fertility. I mostly know about type 2 diabetes. But I just got distracted there into Chillingham cattle because I like cattle.
So on this happy note, I kept trying to find an interesting place where we could wrap up, but at the same time, this is all so interesting. I'm just so happy to have finally had you on, David. And where can people find you?
Thank you for asking. Only really Twitter, Low Carb GP on Twitter. Please follow me on Twitter. I don't have the energy to do any other social media, but I'm there most days. Twitter, or follow the Public Health Collaboration, which is a UK charity with all those free information that you can access.
And by the way, Public Health Collaboration here in the UK has a conference every year.
We have a super conference, usually in London, but we move it around and we really try and fly in some of the most interesting people across the world. So yes, it's every May, our annual conference. And this year, for the first time, there's going to be one in Edinburgh as well in November.
That's great.
Thank you.
Thanks for coming on, David.
You're welcome. You're welcome.